Good morning. I'd like to call this hearing to order. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Wednesday, February 14th, 2024, and the time is 9:31 a.m. Today, we will discuss the FY23 performance of the DC Health Benefit Exchange Authority, also known as HBX or DC Health Link, as well as several health licensing boards, the Board of Dietetics and Nutrition, Board of Nursing, the Board of Massage Therapy, and the Board of Veterinary Medicine. This is a hybrid hearing with public witnesses and board chairs testifying virtually via the Zoom internet platform, and Mila Kaufman, who is the director of HBX, and some of the other board chairs will be providing testimony in person. The Health Benefit Exchange Authority, or HBX, is a quasi-governmental agency of the District of Columbia charged with implementing and operating the district's health benefit exchange. HBX operates DC HealthLink, an online marketplace for district residents and small businesses to compare private health insurance plans, learn if they're eligible for tax credits for subsidies to purchase private health insurance, or qualify for Medicaid and enroll in a health plan that best meets their needs. HBX enables individuals and small businesses and their employees to find affordable and easier to understand health insurance. The DC Health Benefit Exchange Authority operates through the 5 following divisions: the Consumer Education Outreach, Marketplace Innovation Policy and Operations, IT-related operations, agency management, and agency financial operations. The committee sent written pre-hearing questions to both HBX and DC Health, who has administrative responsibilities as it pertains to the health boards, and we will reference those materials today. If anyone watching would like to see those materials, they can be found online on the DC Council website, dccouncil.gov/hearings. I don't see any of my colleagues here, but should they join us, we'll certainly turn to them for an opening statement. Before I get started, I wanted to review the testimony guidelines for public witnesses. Individuals representing organizations will have 5 minutes to testify, and those representing themselves will have 3 minutes. I will give you a nudge when your time has expired. If you're testifying virtually, you'll need to affirmatively accept our invitation to become a panelist when your name is called. And with that, I'll move to the public witnesses. We'll do panels of 7. Lashada Ham Campbell, who's the owner of Petite Scholars, Charlene Roach Glimp, who's a public witness, Judy McKinney, who's a public witness, Veronica Cardova, from the Greater Washington Hispanic Chamber of Commerce, Che Rudel Tabliska, who is from the Restaurant Association of Metropolitan Washington, Al Goldberg, who's the founder of Mess Hall, and Angela Franco, who is the president and CEO of the DC Chamber of Commerce. I'll give it a minute as folks come into the room. All right, I don't see Miss Ham Campbell, but I do see Charlene. Charlene, when you're ready.
Good morning.
Good morning.
And good morning, Chairwoman Henderson and members of the Committee of Health. My name is Charlene Roach Glimp, and I am the co-owner of Petite Scholars West End LLC. Thank you for the chance to testify before you and share our positive experience with the DC Health Link and how the Healthcare for Childcare program has been a game changer for our school and our teachers. Petite Scholars West End is an infant and toddler development center with a Montessori-inspired curriculum located in the Rhode Island Avenue in Ward 5. We are now in our 7th year of operation, and we currently have a team of 11 teachers taking care of 36 children at our center. Our program creates a warm, comfortable, inviting atmosphere for babies to learn, grow, and develop. To achieve this, we need an energetic team of loving caregivers to nurture our child's rapidly developing mind through song, play, creative movement, and rhythm exercises. These are special teachers, and without them, we don't succeed. We value our teachers and other team members And the health care for childcare program has allowed us to support our employees by providing access to free quality health insurance coverage. Before the health care for childcare, many of our employees didn't have health insurance coverage and would rely on urgent care clinics for their care and then pay out of pocket for treatment. Profit margins in daycare centers are very thin for child development centers. We couldn't afford to offer our employees high quality health insurance coverage, and we didn't see a path for our child care center to be able to do that. That all changed with the healthcare for childcare, and our team was so excited when we began to participate. Currently, seven of our employees participate in the healthcare for childcare. And in April, their metal level coverage will go from silver to gold, which this will allow for them to pay lower copays and have a much lower deductible. Healthcare for childcare has been a game changer in our childcare center and how our childcare center operates. Our employees can prioritize their health and use their health insurance coverage when they need it. We are around kids all the time, and kids are quite sick, and we are actually involved in something very similar to that now. So when a teacher is out because of sickness for extended periods, it is a big challenge to overcome because we are a staff of only 11. Our staff turnover is very small, and I know that health for childcare has helped with retention. Lastly, I think healthcare for childcare is very important to the Black and Brown communities in the District of Columbia because of the access to free quality health insurance coverage and likely better health outcomes. Thank you very much for the opportunity to share my experience. I would be happy to answer any questions you have.
Thank you so much. Judy? Oh, Judy, you're on mute.
Okay, can you hear me now? I'm sorry.
Yes, go ahead.
All right, good morning, Chairwoman Henderson, and members of the Committee on Health. My name is Judy McKenney, and I'm the Director of HR for Metro Montessori. Thank you for the chance to testify before you today and share the positive impact that healthcare for childcare has made through the DC Health Link. The impact it's had on our schools and how greatly it has helped the teachers and our staff there. Metro is a network of 6 highly regarded Montessori schools in the greater Washington, D.C. area. We have 2 schools in the district, Broad Branch Children's House and Franklin Montessori School. Both schools are in Ward 3, and each has a unique culture and feel to meet the needs of the community. All of our schools are either AMS accredited or recognized. Both designations indicate that our schools meet or exceed the most exacting standards of Montessori pediology. To meet these high standards, we must have a dedicated team of teachers. It's no secret that childcare teachers are not the highest paid profession. And as I think our previous speaker said, our margins are very, very low. So for us to be able to offer this type of healthcare to them is something that has been a game changer, has made a huge difference in their life. They do it because they're passionate about education. We do our best to take care of our teachers, and the Healthcare for Childcare program allows us to provide our teachers and other employees with free access to healthcare coverage or greatly reduced premiums for their families. Even more importantly, it has high quality coverage. This year is our 2nd year participating in the program, and we were happy to be able to change our standard from silver to gold. I believe our employees greatly appreciate the support they receive from the district through Healthcare for Childcare. We are currently using this as a recruiting tool, a retention tool. When we share that they have access to free coverage, when I say I'm not lying. It's one of the biggest questions we get, almost higher than salary. In addition, our broker's been able to partner with us, creating a flyer that we give to new hires and potential new hires, explaining the program and the benefits to them. It's been an effective tool for teacher retention, making it less likely that they'll look elsewhere since we're now able to offer them not just affordable, but free healthcare. Above all, what it shows is that DC is supporting them. And I think that's really important. If they get sick, they can see a doctor. They return to work more quickly. I also want to tell you today how important I think it is for this program to continue in the future. The program is a godsend for our employees, and it would have a negative repercussion for our schools if it were taken away. The schools would be the messengers of bad news, and I believe we could potentially see high turnover as a result or lose teachers completely. Thank you very much for the opportunity to share my experience, and I'm happy to answer any questions.
Thank you so much, Ms. McKinney. Veronica?
Good morning, Committee Chairperson Christine Henderson and members of the DC Council on Health. My name is Veronica Cordova. I'm the Program Manager for the Greater Washington Hispanic Chamber of Commerce, and I'm here today to testify on behalf of our CEO, Nicole Quiroga, and DC HealthLink Benefit Exchange Authority, which manage and operate the district's online health insurance marketplace, DC HealthLink. Since July 2013, the Greater Washington Hispanic Chamber of Commerce has been in partnership with DC HealthLink, engaging, educating, and facilitating the enrollment process for individuals, families, small businesses, and their employees. To ensure the accomplishment of its mission, we have collaborated with community-based organizations, federal and local governments, entities, and faith-based organizations to extend DC HealthLink service among the Hispanic community and other minorities in the District of Columbia. Today, we are pleased to testify on behalf of the phenomenal and tireless efforts DC HealthLink staff and partners do each day to provide high-quality and affordable health insurance to the Hispanic residents in the District of Columbia. Some of the most recent GWCC outcomes, one is the area of education and enrollment. GWHCC has partnered with DC HealthLink to host one-touch enrollment events. The one-touch enrollment events provide DC residents with an easy and compassionate opportunity to enroll in quality, affordable health insurance. DC residents who qualify for Medicaid, Alliance, and Coverall DC are also served through this one-stop enrollment shop experience. This initiative is executed with the support of Carlos Rosario International Charter School, the DC Department of Human Services, assisted for various NGOs such as Mary Center, Whitman Walker Clinic, Community of Hope, Leadership Council for Health Communities, as well the insurance brokers well-versed in how our community moves. This year, we had a combination of virtual and in-person one-touch enrollments events. Virtual on Saturdays from 9 a.m. to 12 p.m. and in-person on Wednesdays from 5 to 8 p.m. During this process, we have enrolled 243 individuals and families in DC HealthLink Individual and Family Marketplace, as well as in Alliance and Medicaid health plans. During the DC HealthLink's Hispanic Enrollment Week of Action, that hosts on January 21st to January 27th, we partner with DC HealthLink, El Tiempo Latino, Mary Centers, and Children National Medical Center to host the virtual town hall conversation 2024 focused on Hispanic mental health, where Hispanic residents had the opportunity to learn about the importance of good mental health, the impact of mental health in the community, and the various treatment options available to support those experiencing mental illness. We also, from October 2023 to January 24, we have hosted 39 outreach and educational online sessions and in person, and touched approximately 2,250 small business owners to inform them about the benefits of health insurance through DC HealthLink. Through GWCC online and in-person networking events, GWHCC taught residents and business owners to promote and disseminate information during our online and in-person educational sessions, GWHCC co-sponsor events, and our annual business expo. GWHCC is also an active member of the Hispanic Advisory Committee, where we attend to learn about policy updates, marketing trends, and outreach strategies to keep the community leadership engaged with DC Health Link in accomplishing its missions. GWCC, in association with DC Health Link's other small business partners, plays a significant role in hosting DC Health Link's annual Power Up DC Small Business Summit each year. Power Up DC was developed to celebrate and support the small business community by providing enriching business resources and networking opportunities through a range of cutting-edge seminars, special events, and focused presentations. During Power Up DC, government and private sector representatives present the latest business trends and contracting opportunities for small businesses. We also partnered with DC Health Link in promoting its small business marketplace programs in Hispanic media markets, including El Tiempo Latino, Washington Hispanic, and on Radio El Sol. GWCC will continue to work side by side with DC Health Link and its leaders to ensure District of Columbia individuals, families, small business owners, and their employees in the District of Columbia have access to high quality and affordable health insurance. GWCC will continue to focus its efforts in developing creative marketing strategies for outreach,
Thank you.
inclusive of bilingual staff of all identifiable language in the DC demographic.
Thank you so much.
Oh, thank you.
Oh,
Thank
yep,
you
I'm
so
so
much.
sorry. You're about a minute
No
over your
worries.
time. Yep. Che? Is Che on? Che, if you're speaking, you're on mute.
Good morning, Councilwoman. Can you hear me?
Yes, now I can. Go ahead.
Good morning. Good morning, Chairwoman Henderson. My name is Cheridel Tabasol. I am the Managing Director and Vice President of Government Affairs here at the Restaurant Association of Metropolitan Washington. I'm here today to testify on behalf of the DC Health Benefit Exchange Authority, which operates and manages DC Health Link, the district's online health insurance marketplace. RMW actively supports and promotes restaurants and the food service industry in the Washington, D.C. region on behalf of our more than 1,400 members. The industries represented in our membership encompass restaurants, bars, commercial kitchens, caterers, food distributors, and a wide range of service providers, soundly representing the diversity of the local hospitality industry. We have partnered with DC Health Link to ensure the industry is knowledgeable about quality, affordable healthcare options available for small businesses and their district resident employees since 2014. Additionally, as a small business, RMW itself is also a DC Health Link customer and has been enrolled in the small business marketplace since 2014. The food service industry creates thousands of jobs, supports career growth, and plays a vital role in every community across the district. As of the 2022 census conducted by the National Association, there are 2,513 eateries and bars in DC, and 61,400 individuals are employed in the local food service industry, accounting for 8% of employment in the city. The majority of full-service restaurants in the district are independently owned and operated small businesses. During the current DC government fiscal period, October 1st, 2023 through January 31st, 2024, RMW has coordinated outreach through virtual and in-person strategies to encourage enrollment of small businesses in DC Health Link. The strategies have included the distribution of more than 13,000 e-communications, 16 in-person training sessions, meetings, and events, and 50+ social media posts resulting in over 10,000 impressions. We worked with DC HealthLink to creatively highlight the 23-24 open enrollment period during the African American Week of Action from January 15th to the 21st, which also coincided with Winter Restaurant Week. During the promotion, we recruited several popular DC restaurants to participate in a brunch service activation that helped to engage diners in understanding the importance of healthcare coverage. Using QR codes printed on customized tent cards and check presenter inserts, restaurants helped to drive diners to DC HealthLink's website to learn more about available plan options and to enroll in coverage. We were also able to extend this activation at restaurants for an additional week through January 28th. Also, we highlighted DC HealthLink as a partner on the Restaurant Week promotional website, which garnered 8,000 plus outbound links to DC HealthLink, visited by 7,900 unique visitors. Through our monthly virtual sessions called Broker Plus Business Connect, which are held with brokers to educate and encourage enrollment in employer-sponsored plans, RMW has been able to refer several district small businesses to brokers to assist them in the enrollment process. RMW has been able to provide guidance on ways in which businesses are able to extend a variety of options to employees to help offset costs associated with individual plans. DC HealthLink is featured prominently on our website, rmw.org, to reinforce current messaging, incentives, and events. On the RMW side, DC HealthLink is featured in digital banners on our homepage and internal pages, has a dedicated section for the latest news and updates, and is often published in our blog posts. Over the current grant period, October 1st through January 31st, there have been almost 12,000 outbound links from rmw.org to the small business section of dchealthlink.com. RMW also includes pertinent information about DC HealthLink in e-communications to our members through our monthly e-newsletter, weekly operator updates, and dedicated e-blasts. Our strategy for engagement also included providing DC HealthLink information during 11 food safety and alcohol manager training courses held here on site at RMW's offices. As a result, DC HealthLink information is seen by district residents who work in DC small business restaurants. In addition to RMW's engagement activities, we provide feedback, insight, assistance, and support for DC HealthLink's robust schedule of programming activities throughout the year. There's some more detail on this in my written testimony, which I'll submit after this. And I thank you for your time today, Councilwoman, and here to answer any questions you or other committee members may have.
Thank you. Al Goldberg? Al, if you're speaking, you're on mute. Okay, we'll go to Angela Franco.
Good morning.
Good morning.
Good morning, Chairwoman Henderson and members of the committee. My name is Angela Franco, President and CEO of the DC Chamber of Commerce. The DC Chamber represents 1,100 member companies of all sizes and industries and the hundreds of thousands of individuals they employ. Through our longstanding partnership with DC HealthLink, we have conducted wide-ranging outreach to connect businesses across the district with the exchange, and we have worked closely with brokers to assist with the enrollment in health insurance offered through the small business online marketplace. We are proud of the fact that the district has the second lowest uninsured rate in the nation. Within the past year, we have sent more than 900 marketing and promotional communication emails and social media messages, made over 330 phone calls to small businesses, made 383 in-person connections with small business owners, and referred over 50 businesses to DC HealthLink. For greater exposure, the DC Chamber's newsletter and virtual convening announcements include always the DC HealthLink banner as a tagline directing businesses right to the DC HealthLink website. We're also proud of the fact that the 3 of our 4 carriers are members of the DC Chamber. Each of them works with us to inform small businesses of both the changing commercial health insurance landscape and accompanying market trends. Every month, the DC Chamber hosts a member orientation, providing an opportunity for a DC HealthLink representative to address more than 300 new chamber members during the last fiscal year alone. The Chamber also hosted a series of employer advocacy programs webinars in which DC HealthLink educated dozens of attendees on the benefits of providing healthcare coverage to employers. We also hosted the DC HealthLink at our Business After Hours business networking events. The DC Chamber's ongoing small business partnership with DC HealthLink includes outreach and enrollment campaigns designed to inform small business owners about the array of plans offered by the exchange that will help them save money, provide better employee benefits, and offer options that large employers offer their employees when they seek to enroll in, renew, and/or revise their health coverage options. Our annual events provide perhaps the greatest opportunities to promote the benefits of the DC HealthLink. During our 2023 State of the District and Region State of Health panel, the DC HealthLink served as a premium spotlight sponsor. Executive Director Mila Kaufman served as a panelist addressing over 470 virtual attendees. The DC Chamber also recognized DC HealthLink as a partner at our 2023 Chamber Choice Awards Gala, attended by over 900 DC business leaders, employees, residents, and government officials. In 2024, the DC Chamber and DC HealthLink look forward to continuing to build on our past successes. The two organizations are jointly planning to launch both a student intern partnership program and a Hispanic Advisory Committee luncheon. We also plan to initiate our Small Business Accelerator program, all while continuing to move forward with established annual events such as our Health Policy Forum, Small Business Summit, and Women in Business Luncheon. And you have a copy of my testimony. We do multiple activities. We work very closely, and I'm open to have any questions, to answer any questions you may have.
Great. Thank you so much. I want to try again for Mr. Goldberg.
Yes, good morning. Can you hear me this time?
Yes, I can. Go ahead.
Thank you so much. Good morning, Chairwoman Henderson, and members of the Committee on Health. My name is Al Goldberg. I'm the founder of Mess Hall. I'm pleased to offer testimony before you today regarding DC HealthLink and how they've helped our small business grow and attract top-level talent. Mess Hall is a culinary incubator located in Ward 5. We support food entrepreneurs by providing them with commercial kitchen space and some guidance to make their culinary dreams come true. We call Mess Hall a food community because food brings people together, and the fact that we're here to support DC's food community. Honestly, the food service and hospitality industry isn't always known for taking care of its employees, especially when it comes to being able to provide health benefits. When we hired employee number 1, we made sure that Mess Hall signed up for health insurance coverage through DC HealthLink's small business marketplace. There was no way that we were going to be a company that didn't offer health insurance benefits to our employees. Besides feeling a moral duty to take care of our own employees and giving employees access to quality, affordable health insurance, it's a smart business strategy because we can compete with bigger companies for talent. In fact, we include offering health insurance coverage through the DC HealthLink as part of our offer letters to our potential employees. We offer our employees silver level plans through the Care First, Blue Cross Blue Shield. And if we ever need help, DC HealthLink's small business team immediately springs into action. In the food industry, you must have healthy employees to stay open, and an outbreak can be devastating. Healthy employees miss fewer days of work. They can see a doctor when they need to get sick, get treatment, and get back to work much quicker. I also want to use my time to thank the DC Health Benefit Exchange Authority for advocating for the lowest possible health insurance rates and working hard to try and keep rates down every year. We all know that the COVID-19 pandemic was brutal for the food service and hospitality industry. This industry is still continuing to recover economically from the pandemic, and small businesses in this sector are being squeezed with increases related to inflation. As a small business owner, it's crucial to keep health insurance costs down because of labor shortages. Plus, we need to keep our employees covered, both to retain quality talent in a very tough market and because people need access to quality healthcare more than ever because the COVID-19 virus is now with us for good. Thank you for the opportunity to testify, and I'm happy to answer any questions that you might have.
Thank you. And thank you so much to this panel of witnesses. Really appreciate you taking the time to provide testimony on the performance of DC HealthLink. Mr. Goldberg, I will start with you since you were the last one to go, if you don't mind. I was curious, as you all bring in businesses to incubate, are you also connecting them with DC Health Link as well?
Yes, we are. This is something that we encourage. It's, of course, going to always be up to the individual business owner, but we always sing the praises and emphasize the importance of this in accordance with the way that I just testified.
Great, thank you. Ms. McKinney and Ms. Glimp, I thank you so much for being here. I was reviewing the pre-hearing responses with my staff yesterday, and truly healthcare for childcare, I think, is like one of my favorite programs that we do because of how much of a game changer it has been for the industry, but also demonstrating, yes, in the district, we can still do very innovative things and provide care to folks. Ms. McKinney, you said that this is your second year on the program. Did I hear that right?
Yes, that's correct.
Okay. And you said that you all have been able to use this as a recruitment tool. Is it something that you include now in your job postings when you're publicizing openings?
Yes, we advertise that there's free healthcare available to them. And I can't even tell you what a game changer it's been. It is, both employer and employees probably single highest cost.
Right. I mean, behind salaries, of course, but just think it's been so great. Like, I'm looking at the numbers. The number of licensed facilities almost doubled. The number of employers more than doubled. The number of employees and their dependents doubled. This has really, truly been a game changer. Ms. Glimp, same for Petite Scholars. I'm curious, is this something that you all use as you're doing recruitment?
We do use it for recruitment, and I think it's important to note that Lashada was able to join the call. She was
Okay.
having some technical difficulties, but we definitely do use it for recruitment. And what we found is that for our teachers that have joined the program, it's that it brings forth more continuity of care, and they're not having to see a variety of doctors, and they get to choose a primary care physician. And I think that's a game changer for long-term health too. And we're not collecting numbers on the impact, but I think that it is a great space to start.
That's great. For Ms. Ham Campbell, I'll include her on the next panel if that's okay. I don't have any further questions for this panel of witnesses, but it's always great to hear how small businesses are able to use the Health Link in order to better serve their employees. And so thank you, Veronica, Che, and Angela for being here. Thank you. All right, so we'll go on to the next panel. So I'll include Ms. Ham Campbell as part of that. Isabel Hayden, Patricia Fears, Alexandra Jelleret, Karen Curry, Jocelyn Rock, Dennis Angel, okay, Ms. Ham Campbell, when you're ready.
I'm ready. I want to apologize in advance because I am on travel. So there's background noise that I could not just seem to get rid of, but I am ready to provide my testimony.
Okay.
And it's good morning, Chairwoman Henderson and the members of the Committee on Health. My name is Lashada Ham Campbell, and I am the founder of Petite Scholars. Thank you for the chance to testify before you and share the positive experience we've had with DC Health Link and how amazing the healthcare for childcare program has been for us and our teachers. Petite Scholars is an early child development center with a Montessori-inspired curriculum. There are currently 6 Petite Scholars locations. They're all in Ward 5. At Petite Scholars, we want to create an environment that meets the physical, social, and emotional needs of our infants and toddlers. We believe our approach allows our students the freedom to explore as much as they can in the most natural way possible. We currently have 55 team members taking care of over 200 kids across all Petite Scholars locations. For our young learners to succeed, the strength and dedication of our teachers are crucial. The Healthcare for Childcare program allows us to support our teachers in a truly meaningful way. Our teachers who are DC residents are enrolled through DC Health Link's individual and family marketplace. Before healthcare for childcare, about 20 to 25% of our teachers were without health insurance coverage, with the majority of those teachers unable to get coverage through their spouse or for their spouse or partner. Our teachers are dedicated. They are a team that shows up for work, even when there are very difficult circumstances. They don't always prioritize their health. They prioritize our little people that they love and take care of. And now, thanks to healthcare for childcare, they know that they can get the care that they need when they need it, as well as care for their loved ones and their families, their children and their spouses. Healthcare for childcare is another way that our teachers know that they are cared for and how much I value them. Being able to tell our teachers that they have free healthcare coverage helps with recruitment and retention. The Healthcare for Childcare program also lowers our costs. This allows us to use discretionary spending to pay for dependent cover and contribute 100% towards our non-DC residents' employees' children who are under the age of 26 years old. We also use discretionary spending to take care of the team members who may have barriers to care. At Petite Scholars, we have a predominantly immigrant staff, most of whom are Spanish speaking. A huge percentage of our teachers are undocumented residents. The money we save with healthcare for childcare with the program can be now spent on their healthcare insurance coverage. And our undocumented residents who are eligible for benefits such as FMLA means that there's a greater need among those team members to have ongoing healthcare coverage. Not long ago, one of our undocumented teachers was diagnosed with cancer. Because they weren't eligible for FMLA, I paid her salary for the 6 months while she was away to battle cancer. I know if not for cancer, that teacher would have been at work every day on time and providing amazing care to our little ones. And thanks to the Healthcare for Childcare, now we have discretionary dollars to spend on more life events for our staff, as opposed to spending that to pay for their healthcare needs. Having a peace of mind comes with health insurance coverage. It removes the worry for me as a business owner and for our teachers so that we can focus on our most precious resources, our children and our nation's capital. Thank you very much for the opportunity to share my experience. And I would also be happy to answer any questions you may have.
Thank you so much. Isabella?
Good morning. Chair Henderson and other members of the committee, thank you for allowing me to testify today. My name is Isabella Hayden, and I am a registered nurse, certified nurse midwife, board-certified women's health nurse practitioner, and Ward 1 resident. I'm speaking to you today about my concerns with the Board of Nursing's ability to efficiently and appropriately process licenses. I moved to Washington, D.C. in November 2020 from Wisconsin, where I practiced as an RN. I applied for DC nursing licensure before relocating in October 2020. Due to the pandemic, I was able to work and practice under my Wisconsin license while I waited for my DC nursing application to be processed. My application remained pending for 7 months, and when I reached out to the board to understand why, no one was able to tell me. I spent many afternoons and hours on hold as board personnel investigated. I was given contact information for several people, often for individuals who no longer worked for DC Health. After 8 months with no answers, I enlisted the help of Councilmember Nadeau's office, and even they were unable to get information from the board. After 9 months, late July 2021, the board told me there was an issue with my criminal background check, so I contacted the company that conducted it. The company shared that the results of the background check had been sent to the board within a week of my fingerprint submission in October 2020. However, the results were not opened by the intended recipient after 30 days and were therefore deleted per FBI policy. I paid an additional $50 to repeat the background check and finally received my license in early August 2021, 10 months after my initial application and just before the emergency order allowing me to practice under my Wisconsin license expired. Although I'm here to share my own experience, I know from colleagues that mine was not a unique situation. There is a trend of poor communication, lack of transparency, and disorganization within the DC Board of Nursing. I'm here today because I just graduated with a master's in nursing and have achieved board certification as a nurse midwife and a women's health NP. I have an active DC registered nursing license and applied for an advanced practitioner license on January 19th. I applied for that same advanced nursing licensure in Virginia on the same day. Virginia has already reviewed my application and provided feedback, whereas the DC Board of Nursing has not. I'm very concerned that I will again have a delay in obtaining licensure that will prevent me from starting a job in my chosen field within a reasonable time frame. As a result, I'm more actively considering jobs in Virginia than here in DC. I say all this because I worry that the Board of Nursing makes it more difficult to attract clinicians to want to work in the district and progress in their careers here. I'm hopeful that this committee's oversight can help improve the turnaround time on applications. Thank you again for your time and the opportunity to testify.
Thank you, Ms. Hayden. I'll have some follow-up questions if you can stick around. Reverend Fears?
Good morning. I
Good morning.
appreciate your time. Good morning, Chairman Henderson and members of the DC Council Committee on Health. I am Reverend Patricia Hales Fears, and I'm the senior pastor of the Fellowship Baptist Church in Washington, DC in the 4th Ward. And I'm pleased to provide testimony at this hearing about the work of the Leadership Council for Healthy Communities that they are doing with the DC Health Benefits Exchange Authority, providing health insurance for residents of the District of Columbia through the DC Health Link. I truly understand the importance of the work being done by the Health Benefit Exchange through organizations such as the Leadership Council for Healthy Communities. We as clergy leaders lift up the advantages and the importance of having health insurance coverage, speaking to our congregations from our pulpits, in person or through our virtual worship services, our church newsletters and programs. The work of enrolling people in the health insurance and helping them understand health insurance in general and the options that are available to them is critical in improving the individual and community health and a better health outcome overall. To quote the Dr. Martin Luther King Jr., I deeply believe that of all of the forms of inequities, injustice in healthcare is the most shocking and inhumane. This work is a solemn task and a sacred duty. And I commend the leadership and the staff of the Health Benefit Exchange, and I pray they will continue to be successful in their service to DC residents. I appreciate this time, and if you have any questions, I'm available.
Thank you, Reverend Fears.
Absolutely.
Alexandra Jelleret?
Hi, good morning.
Good morning.
Good morning, Chairwoman Henderson and members of the Committee on Health. My name is Alexandra Jelleret, and I'm co-founder of Say Networks. I'm pleased to offer testimony before you today regarding DC Health Link and the positive impact it's had on our small business as well as our employees. Zay Networks is a district certified business enterprise, and we are an award-winning provider of healthcare transformation services and solutions. Our team focuses on providing strategic high-quality services in many areas, including health quality improvement, telehealth, digital health solutions, public health outreach, and health and human services software and application development. I can tell you that Zay Networks has been working overtime since March 2020 with the onset of the COVID-19 pandemic. Our team works both remotely and in person, as some employees work in the office and out of hospitals and healthcare settings. We have been DC HealthLink customers since 2018. We offer employees coverage at all meta level plans through United Healthcare. This way they can choose a plan that best fits their needs. Because we work in the health technology sector, providing our employees access to quality, affordable health insurance coverage is important to us as a company. Beyond that, providing these benefits to our employees helps us as a small business. We can compete with larger firms for high quality employees because we can offer great benefits through DC HealthLink. We're also able to show our team how important they are to us by offering quality health insurance coverage. Offering health insurance coverage greatly helps employee retention, which means less money spent on recruitment and training. On top of that, if a team member does get sick, they can receive treatment from a doctor and return to work more quickly. Before we became DC HealthLink customers, we provided our employees a credit so they could purchase health insurance. However, this didn't always mean that our employees got coverage. Having to purchase insurance on your own could be a daunting, often frustrating experience before the Affordable Care Act. As a company, we are proud to offer benefits through DC HealthLink and feel so much better knowing that our team is covered. DC HealthLink's portal is easy to use, and our team has had great experience accessing their benefits. Also, as a small business owner, it gives me peace of mind to know that our employees have the coverage they need. This was especially true during the pandemic. Having quality health insurance means that our team has one less stressor to worry about, and that makes us feel great. Thank you very much for the opportunity to share my experience, and I'd be happy to answer any questions you may have.
Thank you. Reverend Curry?
Good morning. Good morning,
morning.
Councilwoman Henderson and members of the Committee on Health. I'm Reverend Karen W. Curry, Associate Minister of the Pennsylvania Avenue Baptist Church, PABC, in Ward 7. And I have the privilege of preaching the gospel alongside my husband, Reverend Dr. Kendrick Curry, who's pastor of PABC. As those who minister to the entire person, we believe that health care is a human right. To quote the late Reverend Dr. Martin Luther King Jr., we believe that of all the forms of inequity, injustice in health care is the most shocking and inhumane. To that end, it's my pleasure to speak before you this morning in support of the DC Health Benefit Exchange, DCHBX, and the great work that they have done and are doing for the residents of the District of Columbia to provide quality, affordable health insurance coverage. As a faith-based institution, we are in a unique position to reach uninsured district residents, especially those considered hard to reach. As such, PABC was an active community partner with the DCHBX even before DC HealthLink opened for business. PABC was the site of a Ward 7 community town hall meeting for DCHBX to introduce residents to what was, at that time, the district's brand new online health insurance marketplace, and to answer questions about the Affordable Care Act, which made quality, affordable health insurance plans accessible for individuals, families, and small businesses. During DC HealthLink's very first open enrollment period, we were one of the many DC places of worship that were a part of the final push to enroll residents by the deadline for coverage. We are pleased to have participated in DC HealthLink's Faith in Action Sundays, featuring encouraging messages about enrolling in health insurance coverage shared from the pulpit, with DC HealthLink assisters on site to help with the enrollment process. Beyond Faith in Action Sundays, DC HealthLink has been a staple at numerous community events where staffers and experts have provided critical information about health insurance plans and discuss opportunities for uninsured persons to gain and maintain access to quality, affordable health insurance coverage. As you know, the District of Columbia ranks second in the nation for the lowest uninsured rate, but this doesn't mean we should let up in our outreach. It's critically important that we not stop until every single district resident, especially those in Ward 7, has access to quality, affordable health insurance, which is critical to improved health outcomes. We are thankful to have had the DC Health Benefit Exchange Authority in place to make sure everyone in the district can receive the care they need when they need it. Madam Chair, I thank you for this opportunity to testify before this committee, and I am pleased to answer any questions you may have.
Thank you, Reverend Curry. Jocelyn?
Sorry. Hi.
Hi.
Happy Valentine's Day.
Yes.
Good morning, Chairwoman Henderson and the members of the Committee on Health. And my name is Jocelyn Rock. I'm the one of the assistant teachers here at St. Columba's Nursery School. And I thank you for the chance to testify before you here today and share how life-changing this healthcare for childcare program through DC HealthLink has been and will be for me. St. Columba's Nursery School is in Ward 3 at the Tenleytown Metro stop, where I also live a few blocks away. I've worked at St. Columba's for over 9 years, and I'm a single mom who works 2 side hustles, bookkeeping and tennis teaching after school, in addition to my job as the assistant teacher here. And it's so I can stay in this neighborhood and so that my daughter goes to Jackson Reed High School. As you probably imagine, finances can be tight, and working in a preschool isn't really about the money. It's more about passion, and I love what I do. And having access to free, high-quality health insurance coverage through Healthcare for Childcare program makes it so much easier to make ends meet as a single mom. It's a blessing to be able to live and work in the District of Columbia, and I feel I can breathe so much easier financially Thanks so much to this new program. I looked into participating for healthcare for childcare last year, but ultimately decided against it. When I saw that the free coverage being offered for 2024 was gold level standard plan coverage with lower copays and a much lower deductible, it became a no-brainer for me to sign up. Now I have about over $400 extra each month that can cover like gas bills, or it's basically covers the car payment, and which I'm going to need since my daughter's going off to college in a year or two. So we're visiting colleges. Because of healthcare for childcare, I essentially get a bonus every 2 weeks, and it makes a measurable difference. Healthcare for childcare, access to free health insurance coverage is an amazing gift. I was shocked that it was such great coverage because I figured it would be catastrophic coverage only since it was free. Since signing up, I've told everybody I know who works here and in childcare and other nursery schools to sign up for this program. Thank you again very much for this opportunity. I would be happy to answer any questions that you have.
Thank you. Dennis, Angel?
Good morning, Chairman Henderson and the members of the committee. My name is Dennis Angel, and I am an in-person assistant at Mary Center, a federal qualified health center with locations across the DC metropolitan area. Mary Center employs 2 in-person assistants who implement our health benefit exchange program. Mary Center and the Health Benefits Exchange Authority have had a partnership nearly 11 years. At Mary Center, we witnessed firsthand the impact that as in-person assistants team have in supporting the DC residents accessing health insurances providers through the DC HealthLink Affordable Care Act health insurance marketplace in DC. Within the calendar year of January 1st through December 31st of 2023, our 2 in-person assistants have supported over 2,266 DC residents and their families to obtain health insurance. We conduct in-person assistants and virtual outreach events in English and in Spanish to educate our community health insurance benefits and enrollment process. We are present in the community during evening hours, throughout weekends, and host indoors and outdoors community events. Our dedication and tenacity to maximize opportunities for uninsured DC residents who enroll in health insurance speaks volumes to Mary Center Health Benefit Exchange programs, perseverance to ensure the highest percentage of residents who obtain health insurance coverage. The DC residents we serve express their gratitude for providing culturally specific services in their native languages, especially within increasing health insurance literacy and enrolling qualifying health plans. We have appreciated the partnership and leadership of the DC Health Exchange, working with us to ensure that the staff are trained and supported in their roles, and to help identify and arrange events that can best meet those who still lack insurance. Thank you for this opportunity to testify, and I will be happily able to answer any questions that you might have.
Thank you. And thank you so much to this panel of witnesses for your testimony. I'll start with Ms. Ham Campbell, because I know that you're traveling. I thank you so much for your testimony and for all that you do serving Ward 5 families in terms of the locations, but also I think the heart that you guys show to your employees, especially the example that you gave of an employee who was diagnosed with cancer. And because of some of the freed up funds, you guys were able to continue to pay her salary while she was in treatment and recovery. And I think that's, some of the goals of what we were trying to do with healthcare for childcare. And even with the Pay Equity Fund, which was to ensure that our childcare centers can not only survive, but also thrive for their employee base. So thank you so much for being here and for the work that you do as well. Miss Rock, if you're still here, I know you're probably teaching too, or in between teaching. I wanted to ask, you talked about the switch from silver to gold, and we noticed that as well. The change in terms of the deductible. How were you informed about the switch of what was offered, or was this something that you sought out? Ms. Rock, are you still with us? Okay, maybe she might be tied up on doing something else. Ms. Hayden, are you still with us?
Hi.
Hi, thank you so much for being here. We've already had the performance oversight hearing specifically for DC Health. But in that, we were able to pull the numbers, and in FY23, the average timeline of them processing an application for a registered nurse was 44 days. A nurse anesthetist was 218 days, and the average timeline for a nurse practitioner application was 66 days. I appreciate you testifying on your particular experience, because anytime we ask DC Health about the processing timelines and why it's taking so long, they usually point to, oh, it's something that the applicant hasn't done or the applicant hasn't completed. But in your situation, you completed it. They simply didn't open the necessary application materials in time before it disappeared.
Mhm.
Is that accurate?
That is accurate. Everything was done probably within about a week, and they were for whatever reason, they did not open the results of the background check. And more than that, they didn't let me know that that was the issue.
Right. I think that's also the most frustrating part too, of saying, oh, it's something with your application that you've done, or even the fact that it took them 10 months to figure that part out, or for someone to say what was happening on that front. I can only imagine then how many other people have been in a similar situation where they did everything they were supposed to do, but nobody actually opened the background application results. And therefore they expired. And instead of saying we didn't do our part and we're going to pay for it, the government side, you had to pay for it again. So you said that, well, first off, congratulations on getting your master's.
Thank you.
How long has your current application been pending for?
It's been pending since January 19th. So if I'm doing the math, it'll be almost 5 weeks this week.
Okay.
Yeah.
But you said Virginia had already moved forward.
Yes. So yeah, Virginia already contacted me asking about a certain part of my application. So I know that they've already actually looked at it. And that was the same case when I applied for just a regular RN licensure in Virginia. I had my license within 1 to 2 weeks, and I had notification that it had been viewed within a couple of days of submitting it. So I knew that a human had looked at it.
Right. Okay. I think we can, we'll follow up specifically on this, because, I think in the mass competition that we have, especially for nurses, when I think about the issues we have with school nurses and our hospitals and our nursing facilities, I don't want people taking jobs in Maryland and Virginia simply because we can't get our act together to process an application on time. So I appreciate you raising this and for being here. Reverend Curry, I wanted to ask, thank you so much for being here. I wanted to ask you a question. So, you all have been helpful in sort of putting information out around getting folks covered. And one of the things when I think about DC, right, we boast in terms of the fact that I think we're second in the country in terms of health insurance coverage. So it's not as though people aren't getting covered. But when I look at the data from healthcare finance in terms of, or even DC Health in terms of health outcomes, we have these massive health disparities across the board. And I sort of think, it's hard because we can get someone covered, but I can't make you actually go to a doctor's appointment. And so how do you all view in the faith-based community doing that extra step, right? Now that we've got you covered, let's keep you healthy while you're here.
Well, thank you for that question. Pastor Fears alluded to it earlier. The Leadership Council for Healthy Communities is an organization that we participate in at the Pennsylvania Avenue Baptist Church, and a number of churches throughout the DMV, but most of which are in the district, participate in providing what we call services through health navigators, people that work with partners like those at the Health Exchange and DC Health and local providers and others to do just that. And so that is our goal, to make that connection, to encourage people to take advantage of the resources that they have, to check and make sure they have adequate insurance. Our health needs change over time. Circumstances can make your health needs change in a moment. Aging can make it change, and other life issues. And so we actually work with our congregation and the community to do that and connect people with providers, make sure they actually have the insurance that they need. And that's a long process too, because it's relationship relationship building and trust building, but that's what we're committed to doing. And we're thankful to the Leadership Council for Healthy Communities for their efforts in bringing churches together to do that.
Great. Well, thank you guys so much for being here and for your testimony. It certainly adds, color and context to the work that we're doing. We're going to go to our next and final panel of public witnesses, and then we'll turn to the government. Sia Barbara Kamara, Jay Yarborough, Paulette Sheffield, Rebecca Barson, Kathy Hollowell Mackle, Lisa Nip, Rakaya Anbar Shaheen, Janice Haynes Davis. And again, for folks who haven't done virtual hearings with us, you have to affirmatively accept our invitation for you to become a panelist. All right, Miss Kamara.
Well, good morning, Chairwoman Henderson, members of your committee and the Committee on Public Health. I'm Sia Barbara Kamara. I'm a longtime Ward 4 resident, and I'm the Chief Strategy Officer for the DC Early Learning Collaborative. The collaborative is an early childhood advocacy organization that was instrumental in the passage of the Pre-K for All DC law in 2008 and the Burglary for All DC in 2018. I'm also a member of the DC Association for the Education of Young Children and a member of the Advisory Council for the Under 3 DC campaign. Today, I want to testify on the successful implementation of the Healthcare for Child Care program by DC HealthLink, formerly known as the DC Health Benefit Exchange Authority, under the leadership of Mila Kaufman. We applaud Ms. Kaufman, Executive Director, and her team for their outstanding efforts to bring this long overdue benefit to the early childhood profession. They are a sterling example of how public servants working together with partners can unpack free and low-cost financial healthcare benefits for thousands of childcare professionals in Washington, D.C. As you are well aware, D.C. leads the nation in early childhood education on multiple fronts, including the provision of universal pre-K and infant and toddler care, and pay equity, and now health care for child care benefits. None of this would have been possible were it not for the vision and leadership of the council, especially you, for which we are most appreciative. The Early Learning Collaborative believes that a healthy childcare workforce is pivotal to providing quality childcare for children. Furthermore, we believe that a healthy early childhood workforce contributes to the district's educational improvement efforts and the city's overall economic vitality. I want to share some strategic steps that DC HealthLink implemented to more than double the number of persons receiving this new health benefit who are working in early childhood development centers and homes licensed by the Office of the State Superintendent of Education. DC HealthLink realized that they needed to reach out to organizations and individuals who were trusted voices in the early learning community with a proven history of community support and advocacy, a key component and necessary for the effective implementation of healthcare for childcare. This resulted in the establishment of a Healthcare for Childcare Advisory Committee in late 2022. That advisory committee has met bi-monthly since its inception. And we have certainly helped the exchange with its policies, communications, and outreach. A key recommendation from the advisory committee resulted in the establishment of the Healthcare for Childcare Outreach and Engagement Partnership. This is a grant program. The OEP partners with 5 professional associations. And together, we meet bi-weekly and share strategies, and we are updated. A real game changer that should significantly increase participation of individuals and early childhood enrollment in the program began on January 1st. And that's when we switched from the silver plan to the gold plan. You've already heard from others about how this has impacted. I conclude my testimony and I am available to respond to your questions.
Thank you. I don't think Jay Yarbrough is here. Paulette Sheffield?
Yes, good morning, Chairwoman Henderson and members of the DC Council Committee on Health. I am Paulette Sheffield, Lead Assistant for Leadership Council for Healthy Communities, LCHC. I am pleased to provide testimony at this hearing for LCHC, an organization of clergy leaders, medical professionals, public and community leaders working together to help African Americans and other communities of color eliminate health disparities and promote healthy communities through comprehensive health programs. LCHC is doing work under the auspices of the DC Health Benefit Exchange Authority. We have had the privilege of serving as an sister organization of the Health Benefits Exchange since its inception. We know firsthand the great work the exchange is doing for DC residents in providing health insurance through the DC Health Link. LCHC has worked diligently to help district residents gain and maintain health insurance coverage, and recently have placed special emphasis on Medicaid unwinding and healthcare for childcare. When DCHBX launched the Healthcare for Childcare program, LCHC assisters visited licensed child development centers and homes to enroll childcare workers and/or childcare sites in health insurance plans and provide information on health plan options through DC Health Link. Additionally, to inform healthcare for childcare workers about their eligibility for health insurance, calls and emails were made to over 75 childcare workers and/or childcare providers. We helped staff virtual one-touch events on Saturday mornings and weekday evenings to assist healthcare workers at times that were more convenient for them to enroll and get information to make informed decisions about their health insurance options. Special emphasis was also placed on Medicaid unwinding to assist persons who may be losing Medicaid coverage to renew their Medicaid or assist them in enrolling in other healthcare plan options with DC Health Link. Over 100 calls and emails went out to people for this Medicaid unwinding effort. LCHC also engaged in a robust outreach effort to be accessible and provide opportunities for people to enroll in health insurance plans or obtain information that would allow them to make informed decisions. LCHC assisters were assigned weekly throughout the year at 3 locations: Department of Employment Service Backus Campus, Martin Luther King Jr. Library, and Preventive Measures Health Clinic. Additionally, outreach efforts included participating in special events and activities at the request of the Health Benefits Exchange, including the Mayor's Career Job Fair, DC Open Street, the Mayor's DC Early Education Expo, and the Mayor's Maternal and Infant Health Summit. During African American and Faith in Action Week, we arranged for Mila Kaufman, Executive Director, to speak before the Wednesday Clergy Fellowship Group to share information on DC Health Link and the importance of having health insurance. The outreach also included tabling events at health fairs, faith institutions, vaccination pop-up clinics, barbershops, beauty salons, as well as arranging for stickers and pamphlets to be distributed at several restaurants throughout the city. LCHC's outreach effort provided widespread opportunities to enroll persons in health insurance and educate audiences on the importance of being insured. We commend the leadership and staff of the Health Benefit Exchange in this critical work in helping to improve individuals and community health in the District of Columbia. Thank you for this opportunity to allow LCHC to testify this morning, and I would be happy to answer any questions.
Thank you. Rebecca Barson.
Good morning, Chairperson Henderson and members of the Committee on Health, and thank you for allowing me to speak before you today. My name is Rebecca Barson, and I'm a Ward 3 resident. I'm also the owner of RDB Strategies, a small health policy and advocacy consulting firm, a proud DC HealthLink customer, and a member of the DC Health Benefit Exchange's Standing Advisory Board. As you consider the DC Health Benefit Exchange Authority's FY 2023 performance in today's hearing, I want to share with you the positive impact that DC HealthLink has had on my life and career. Just over 8 years ago, in early 2016, DC HealthLink enabled me to fulfill a lifelong dream of self-employment by allowing me to purchase high-quality health insurance that I could afford as a small business owner, something that had been unattainable before the existence of the Affordable Care Act and the health insurance marketplaces it established. And one of the reasons that I needed to ensure that I had such coverage is because I am part of the nearly half the population that has a chronic condition. Particularly, I'm one of the 47 million Americans who have migraine disease. In my case, it is chronic, meaning that I have more than 15 migraine days a month, and it significantly affects my quality of life. Excellent insurance coverage is essential. And I have found that through DC HealthLink. I've had coverage for the past 8 years with CareFirst, Blue Cross Blue Shield, and I'm grateful for their broad network of providers because I have to see a lot of providers to get the right care for my condition. With my PPO plan, I have been to see providers at Jefferson Headache Center in Philadelphia, considered one of the best headache care facilities on the East Coast on an in-network basis, along with local providers at MedStar Georgetown Headache Center, in order to find the right combination of care for me. While I continue to search for the best treatments that will help me feel my best, it is such a relief that my insurance coverage isn't a barrier to these efforts. The coverage I have through DC HealthLink really is as good or possibly better than what I would have through an employer. I also appreciate DC HealthLink's efforts to obtain rates as affordable as possible for their customers so I can continue to afford this excellent coverage. One other thing that I want to share is about my work on the Standing Advisory Board. One of the responsibilities with which the Standing Advisory Board is charged is to approve special enrollment periods for DC HealthLink. This year, we approved a special enrollment period for healthcare for child care eligible employees of child development centers and homes licensed by the Office of the State Superintendent of Schools, OSSI, and their dependents. This unique partnership between DC HealthLink and OSSI is expanding healthcare insurance to early childhood workers, a population that is especially likely to be uninsured. While we on the Standing Advisory Board played only a very small role in this program, I am still proud to have been involved even in a small way because I know what a difference high quality, affordable health insurance can make in someone's life. And it's been so gratifying today to hear the stories of just what a difference this program is making. Thank you, Chairperson Henderson, for the opportunity to share my experience with DC HealthLink today, and I'm happy to answer any questions.
Thank you. Kathy?
Good morning and happy Valentine's Day. Good morning, Chairwoman Henderson and the members of the committee. My name is Kathy Hollowell-Mako, and I am the Executive Director at the District of Columbia Association for the Education of Young Children and a proud Ward 7 resident. I am also the co-chair of the Health Benefits Exchange Advisory Committee. My organization, also known as DCAYC, is a professional membership organization that works with and supports all those who care for and educate young children and their families in the District of Columbia. DCAYC is committed to securing a solid start for every young child in the city by supporting the educators who ensure their daily development, their curiosities, and their safety. My testimony today supports the work of the Health Benefits Exchange on the groundbreaking implementation of the Healthcare for Childcare program. A 2022 brief by the Urban Institute entitled The Pandemic's Effect on Early Educators' Employment and Well-Being, Findings from the District of Columbia Child Care Policy Research Partnership reported that in 2022, 44% of the DC early care and education workforce were ineligible to receive health insurance through their employer. Now, council members are well informed about the struggles of DC's early education workforce, which is a predominantly women of color field that has been historically undervalued, undersupported, and disproportionately affected by the need to find and secure economic and wellness access points. When the Early Educator Equitable Task Force met to discuss the implementation of the Pay Equity Fund, easing the burden of finding and securing such access points was and remains a priority. As an Early Educator Equitable Task Force member, I can attest to all the thought and effort poured into implementing the Pay Equity Fund for the 4,000 plus early educators across all settings. One intention has been to include healthcare benefits as integral to comprehensive compensation for all early educators in the city. Healthcare for Childcare's offerings has provided healthcare for wellness and preventive care for our early educators, ensuring the best quality of life for them. The Health Benefits Exchange has done an extraordinary job of outreach to early educators and child development programs. Direct outreach and community outreach grants awarded to credible and trusted voices in the early learning community have worked to expand public awareness by connecting eligible employees of OSCE licensed programs to assisters for easy and secure enrollment. Enrollment in the program is steadily increasing as early educators and programs become confident in the consistency, the quality, and the stability of the healthcare for childcare offerings. As with most new initiatives, it will take time to see full participation as a healthcare option has not been available for many in the field previously. And they have, and also to veteran teachers during their careers. However, with consistent and continued outreach, public awareness, education, and dedicated funding, DC's early educators will benefit from comprehensive compensation that includes economic, mental, and physical wellness. Our early educators, young children, and their families deserve it. Thank you for the opportunity to testify, and I'm happy to answer any questions.
Thank you. Lisa?
Yes, can you hear me?
Yes.
Oh, great. Well, good morning, Chairwoman Henderson and members of the Committee on Health. My name is Lisa Knipp, and I'm a Ward 6 resident. I thank you for allowing me to speak before you today regarding DC HealthLink and the positive impact it has had on my life as a small business owner in DC. I have health insurance coverage through DC HealthLink's individual marketplace. DC HealthLink and the Affordable Health Care Act have allowed my family to purchase health insurance multiple times for almost a decade as my family's employment status changed. I have worked as a self-employed corporate photographer for over 20 years, and I am now a single mother after the death of my husband from cancer 2 years ago. Without DC HealthLink, I would be unable to afford coverage for me and my son. My family has been DC HealthLink customers on and off since 2015. At the time we became DC HealthLink customers, we didn't have employer-sponsored health insurance through my husband's job as a baseball analyst. Despite not qualifying for premium reductions because of our income, we were able to afford coverage with lower deductibles at better price points as the years went on. We were very pleased with both the quality of our medical and dental plans and the customer service provided by DC HealthLink. We left DC HealthLink when my husband's job offered employer-sponsored coverage. During the COVID-19 pandemic, my husband's television show was canceled and he was laid off. My photography business shut down completely. Neither of us worked during most of 2020. Masson, his employer, kindly continued to allow my husband to remain on their insurance plan since he was ill. But my husband and I were removed from this plan in September. My son and I were removed from this plan in September of 2020. After all I had been through dealing with insurance billing during my husband's sickness, I was terrified of being without insurance myself in case something else happened. I reached out in tears to DC HealthLink, and within 24 hours, they contacted me with a person who helped enroll my son and me in a Medicaid plan. With the passage of the American Rescue Plan, I received a notice from DC HealthLink about premium reductions. This notification came around the same time that my income recovered enough that I was no longer eligible for Medicaid. However, I did not think I could afford to buy a plan on the exchange. I worked with a DC HealthLink representative and found that I qualified for a silver level plan at an affordable $111 a month. It was such a relief to know that I had this coverage and that I could return to the doctors and other healthcare providers I had used for years. After the Inflation Reduction Act extended lower premiums from the American Rescue Plan in 2022, we were able to stay with the Silver Plan last year. My income has recovered significantly since then, and thanks to the federal monthly tax credit, I have a 2024 standard Silver Plan with CareFirst Blue Cross Blue Shield that saves me more than $8,700 a year. Our healthcare plan is always at the forefront of my mind. I have seen firsthand that good insurance prevents financial ruin during times of life-changing illness. The standard silver plan I have through DC HealthLink allows me to sleep at night without worry because I know that I have coverage that will provide for the care I need, a deductible that I can afford, and the support of the customer service representatives at DC HealthLink. Thank you for the opportunity to share my healthcare journey. I am happy to answer any questions that you have.
Thank you. Rakaya?
Hello, good afternoon, Chairperson Mendelson or Henderson. I am in a child care center about to go into a meeting, so excuse any noise. Thank you for the opportunity to address you today. My name is Ruqayya Ambar Shaheen. I'm the Director of Early Childhood for DC Action and member of Under 3 DC, as well as a member of the Early Childhood Educator Equitable Compensation Task Force. I'm also a Ward 5 resident. My remarks today will focus on the Health Benefits Exchange Authority's rollout of healthcare for childcare. As you know, for too long, early childhood educators have borne too low wages and a dearth of benefits and supports, and a resulting limited opportunity to grow in their field. The Council, in establishing and funding the Pay Equity Fund, has made the needed and transformative change in the district's early learning system by not only compensating early childhood educators on par with their peers in public schools, but by also ensuring that the Pay Equity Fund could support free and affordable child healthcare benefits for child development facility staff and their families. Thank you, Councilmember Henderson, for your efforts to make this possible. In particular, DC is truly leading the nation on this issue. The Health Benefits Exchange Authority has been an excellent steward of this program. We're pleased that employer participation in healthcare for childcare has doubled in the last year, while individual enrollment has more than quadrupled. The authority did not design the perfect program from the start, but quickly learned and adapted their approach based on feedback from those they serve. Through this learning, the authority has revised the types of healthcare the program offers, from silver to gold plans and other important changes. A strategy that the authority employed early on that has proven to be successful is its engagement of an advisory group that regularly reviews enrollment data and makes recommendations about how to strengthen the authority's strategy, including establishing the Outreach and Engagement Partnership Grant that Sia Barbara mentioned earlier to conduct one-to-one outreach and education and to facilitate award handoff to the Health Benefits Exchange Authority. These partnerships have been pivotal to not only increasing enrollment in healthcare for childcare, but also in informing the authority about adaptations needed to improve the program. Another unique approach the authority has taken is to closely review individual educator eligibility for public benefits to ensure that those educators eligible for Medicaid receive a warm handoff and support enrolling. This removes the burden from early learning staff of navigating complex eligibility processes in multiple systems and minimizes public dollars by using federal funds first. Further, by design of the Pay Equity Fund, early childhood educators' salaries have begun to increase, which will naturally result in changes to their eligibility for public programs. The authority works closely to monitor these changes and to coordinate with the Department of Healthcare Finance to facilitate a smooth transition between programs. In January, the authority administered a survey to early learning programs and learned that providers, employers were interested in dental benefits as well. We look forward to working with the authority and with the council if their authorization is needed to explore opportunities to support this need. We look forward to continued growth and enrollment in healthcare for childcare and to working closely with the authority to identify opportunities to strengthen the program. Thank you for the opportunity to testify. I welcome your questions.
Thanks, Rakai. Janice?
Good morning. Hi, I'm Janice Haynes Davis, and it's a pleasure to speak with you, Chairwoman Henderson and members of the committee. My name is Janice Haynes Davis. I am a broker with Davis Platting Associates, the Living Capital Group, and it's located, I'm an owner in Ward 4, where I both work and live. I've also been a longtime partner of DC HealthLink, serving on their Social Justice and Health Disparities Working Group and the Standard Working Plan Group and the Broker IT Working Group. Happy Heart Healthy Awareness Month. The DC Health Benefit Exchange Authority from the beginning has sought input and consensus from community stakeholders as they develop policy, implemented new initiatives, and served district residents and businesses. In the early years, I provided my input on how DC HealthLink could coordinate with brokers to serve clients. I am personally invested in my most recent work task with DC HealthLink on health equity. I served as a member of the DC Health Benefit Exchange Authority's Social Justice and Health Disparities Working Group. We heard from numerous experts and developed recommendations in various areas related to health insurance coverage provided by DC HealthLink. This work is critical to changing how Black, Hispanic, and other minority communities are served and treated in healthcare, especially as it relates to health insurance coverage. One of the consensus recommendations we made was as follows: to modify insurance design for DC HealthLink standard plans to eliminate cost sharing, including deductibles, coinsurance, and copayment for medical care, prescription drugs, supplies, and related services. This helped manage diseases and health conditions that disproportionately affect patients of color in the district. So far, we've focused on 3 areas: diabetes, childhood mental health, and cardiac and cardiovascular disease. The Standard Working Plan Group meets each fall and is staffed by HBX, actuaries, medical experts, and DISB joins, and it includes insurance carriers, consumers, and others. We meet for weeks to discuss different benefit plan designs, their changes, and what medical services would have lower or no cost sharing, and whether the plan changes meet the standards for the particular medical levels. There are DC HealthLink bronze plans with deductibles as high as $7,500 and cost sharing as high as $45 for a primary care visit and $105 for specialty visits. This work will have a real impact upon people because they will be able to get insulin and proactively see their doctors, take their children to receive mental health therapy, and more. I've been honored to be able to add my voice and describe how this would help my clients, my employers who I serve, myself, because I'm also a DC HealthLink participant, and their employees to access care. In conclusion, the exchange's process of seeking input from stakeholders, working toward consensus recommendations, and developing particular partnerships within trusted community voices, many of which we've heard today, has created a first-rate marketplace with competitive choices, a streamlined choice to use application, and strong customer service. And I can really comment on this because I'm a broker. I work in Maryland, DC, Virginia, New York, all over, and really is one of the most competitive and transparent marketplaces. I am proud and excited to partner with the exchange and to serve on the Social Justice and Health Disparities Working Group, the Standard Plan Working Group, and the Broker IT Working Group. I appreciate today's opportunity to testify, not only as a DC broker, but as a generational resident who is an activist and deeply concerned about our city. This collaborative effort is unique, and it illustrates the progress we can make when community, industry, institutions, and government all work together to create a more equitable and healthy place to work and live. Thank you, and I'm open to any questions you may have.
Thank you. Thank you to this panel of witnesses for your testimony and for the work and advocacy that you all do for your various constituency groups. Ms. Nip, I think you've testified before us before, and so it's good to hear that your experience with DC HealthLink continues to be a good one. So thank you so much for being here. Ms. Anbar Shaheen and Ms. Hollowell Mackle, thank you so much. Well, and also Ms. Kamara, thank you so much for being here and for the work that you guys have done in trying to ensure that healthcare for childcare is a program that is actually working well and working well for the folks that we're trying as best we can to reach. I don't have any specific questions for this panel of witnesses. It's an unfortunate thing of you guys being the last panel of public witnesses because so many people have already mentioned some of the things that you have said, but thank you so much for being here. Really appreciate that. We're gonna move on to our first government witness, which is Mila Kaufman, who's the Executive Director of HBX. And she's here in person. Great. All right. Before you begin, I will ask that you or any members of your team who might testify today, I must swear you in. All right. If you raise your right hand, do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the whole truth and nothing but the truth? Great. When you're ready. If you just turn your mic towards you and on, there you go.
Thank you very much. Can you hear me?
I think we can hear you. Yes.
Okay, wonderful. Good morning. Thank you very much. I do have members of my team here. In the unlikely event, I can't answer one of your questions. I will ask one of them to come up and provide you with the information that you're asking about. But good morning. I wanted to start by thanking you, Chair Henderson, for your strong support over our efforts over the last 10 years. We're actually celebrating 10 years of being open, and it's significant. And today I'd like to take you through our journey. Of course, you'll remember firsthand how we started back in 2013 when you were a senior staff person here at the council. So you wore a slightly different hat, but I'm sure you remember all the hearings you had on us almost every other month to make sure that we actually opened our doors on time, which we did. And we appreciate your ongoing support for our efforts. So I'll start with a little bit of background, and then I'll give you an update on our open enrollment and the Inflation Reduction Act. And then I'll give you an update on our implementation of healthcare for childcare. I'll give you an update on Medicaid unwinding support, and I'll close out my remarks by giving you an update on another priority area of ours, which is equity and our social justice work. As you know, HBX is responsible for DC HealthLink, the Affordable Care Act online health insurance marketplace here in the District of Columbia. And although we were the last to start building our IT system back in 2013, we were one of 4 state-based marketplaces that opened for business on time and stayed open on October 1, 2013. I'd like to take us on a journey back to pre-ACA days. And the reason I want to talk about pre-ACA, pre-Affordable Care Act, is because unfortunately, once again, the Affordable Care Act is being politicized and is being talked about in the context of politics. And of course, you and I know that when cancer strikes, it doesn't ask you whether you're a Republican or a Democrat or if you voted or didn't vote. It just strikes. So for us, it's never been political in any way. But it's important to remember why the ACA is important. And of course, before the Affordable Care Act, we had 45,000 people who died each year, preventable deaths, because they didn't have health coverage. People were locked into their jobs. They couldn't leave their job because they were worried they couldn't get new quality health coverage. And you had to be in almost perfect health to get coverage because insurers could just say no to you. They can deny you coverage. They can charge you higher rates. Your existing medical needs, your pre-existing conditions didn't have to be covered. And of course, it was almost impossible to get maternity coverage if you needed it. And coverage had limits, annual and lifetime financial limits. Of course, the ACA changed all of that. So everyone has to be able to get covered. Insurers cannot say no to you. And insurance companies have to cover your medical needs. They cannot charge you high rates because you have medical needs. They cannot charge you high rates because you're a woman. And there are no more annual and lifetime limits. So health coverage actually must work for you, not just when you are healthy, but also when you are sick. And of course, the ACA made premiums more affordable for residents and families. And since I'm taking us back on this journey, DC has always been a leader. And in fact, in the early years, President Obama was so impressed with our outreach efforts, he actually decided to have a conversation with some of our DC HealthLink assisters. So, and so that's a picture of him with our DC HealthLink assisters. And our outreach efforts were featured nationally. As you can see, we leveraged current events like the Super Bowl to help advertise availability of affordable health coverage. We also had the full support of our employer, our business community, our advocacy community, our local elected officials, policymakers, as well as the Obama administration, White House officials, as you can see in these pictures from our early years. And I also want to mention that our Congresswoman, Eleanor Holmes Norton, has attended every single open enrollment kickoff that we've had since day one. And we appreciate her advocacy for us and the Affordable Care Act. And what the ACA has meant for us, this is a survey from the early years where we asked our customers about their health insurance before the ACA, and 1 in 4 said they didn't have coverage before. 1 in 2 people who were determined eligible for Medicaid said they didn't have coverage, and 4 in 6 small businesses said they did not have coverage before we opened. And now, of course, the success, and this is not just DC HealthLink doing our job. This is a reflection of all the support we've had from you, Chair Henderson, from other council members, from our mayors, from our business community advocates, brokers, providers, and everyone we work with. So now we are at near universal coverage, where nearly 97% of DC residents are covered. And since we've opened, we've helped to cut the uninsured rate in half. We cover approximately 100,000 people, and that includes more than 5,200 district small businesses and nonprofits. And we work with more than 900 DC HealthLink brokers providing free help to our customers. And this past open enrollment, just like prior open enrollments, was a big success. And I want to thank you for helping us kick off this most recent open enrollment by coming to MLK Library and helping us with the kickoff. We have 27 plans from Care First, Blue Cross Blue Shield, and Kaiser for our residents. And more residents qualify for lower premiums thanks to the Biden administration and the Inflation Reduction Act, making it even more affordable. We estimate that our residents save about 36 million annually in lower premiums. And we have health insurance coverage for as low as $13 a month. On average, we estimate that families save over $6,000 a year. Now, those lower premiums are set to expire December of 2025 next year. So we are working very closely with other state-based marketplaces, our federal partners, consumers and patient advocates and others to advocate for Congress to make lower premiums permanent. Now, switching gears, another example of how DC continues to lead. Healthcare for childcare through DC HealthLink. It helps, this new initiative, a year old, helps OSCE licensed child development facilities provide affordable health insurance coverage for their employees, either free premiums or lower premiums. And this program is important to us for many reasons. You heard from some of our customers who are benefiting. I want to just recognize it was not HBX doing this program by ourselves. It was the vision that the advocates had, that you as elected policymakers had, and in coordination and a strong partnership that we have with OSCE, we are privileged to be implementing this program that makes health coverage affordable and gives people who work in early child development a way to afford the health care that they need. So it has been a privilege for us to be implementing this program. And in about a year of the program, since we've started this program, we've doubled enrollment. And so now we cover nearly 1,500 people through healthcare for childcare. And I just want to underscore that didn't happen overnight. It happened with all of our partners helping us reach employers and reach workers to get them signed up. We're not done, and we're not going to be done until we reach every single worker in the early child development area to get them covered if they don't have other affordable health coverage. A big change for this year is that healthcare for childcare pays for gold standard plans. And what that means is if you are a DC resident worker in early child development, you and your family can get gold standard coverage at no cost to you for your premiums from Kaiser Permanente or Care First, Blue Cross Blue Shield, HMO, or PPO. And if you were already enrolled in healthcare for childcare in a silver plan, we automatically renewed you into a gold plan. And we wanted to make it as easy as possible for folks who are already enrolled to benefit from a plan with lower out-of-pocket costs. And just to give you a sense of the difference, the deductible difference is quite significant between silver and gold level coverage makes it easier to afford actually getting health care. So this was an important policy decision for us to make it more affordable to actually get care. We also moved the employers who are offering healthcare for childcare into gold level if they were covering workers at silver level. Now, some of the employers decided not to make that change, but for those that wanted us to move them into the gold level, we did that. So there were 45 employers we moved into gold. And then everyone else, all the other employers who were offering gold already or platinum, we applied the larger discount, making it even more affordable to afford premiums. The Healthcare for Childcare program has been, as you heard from other witnesses, a game changer. About half of the employers who enrolled did not offer health insurance before. And almost 900 employees are now getting free health insurance premiums. Now, the employers who did offer coverage before, we've observed that the take-up rate of coverage increased substantially. And so employees who were saying no before, who couldn't afford their share of the premium, are now saying yes to coverage and are getting enrolled. So it's made a big difference for workers in early child development facilities. A quick update on Medicaid redeterminations. We adopted a special enrollment period very quickly last spring. And what that means is anyone who is losing Medicaid coverage because they're no longer eligible, and if they're a resident, they can enroll in our individual and family marketplace. And if they're not a resident, but let's say they moved out of DC and now they live in a different state, but they still work for an employer who gets their coverage through DC HealthLink, we also adopted a special enrollment period for all of our employers. And so folks losing Medicaid can enroll in their employer's coverage as long as the employer is offering coverage through DC HealthLink. I want to just do a quick update about our equity work. And Chair Henderson, you mentioned this earlier. How is it that we have a 97% insured rate, but yet have such significant differences in health outcomes? Well, there are many complex reasons for that. We are focusing on a couple of those reasons and taking steps to alleviate that difference in health outcomes. So I want to talk about two of those areas that we're focusing on. A few years ago, when the pandemic data shed the light on hospitalizations and deaths based on race and ethnicity, and when we all witnessed George Floyd's murder, our board and our staff, we wanted to make a difference and do our part to make a difference, to start addressing institutionalized racism in healthcare and to work toward improving outcomes. So health outcomes are no longer based on the color of your skin or your background. And so two of the areas I want to focus on today is our equity-based benefit design. And we wanted to move our standard plans to equity-based benefit design because we recognized that cost is a barrier to getting care. And you have a different outcome if you can't afford your doctor or your medicine. And so we wanted to remove the financial barriers for conditions that disproportionately impact communities of color in DC. And we know that cost is a huge barrier. For example, our Hispanic and Latino residents report that at twice the rate as white residents, they have problems seeing a doctor because of cost. They can't afford it. 10% of our Black residents compared to 6% of our white residents report not being able to see a doctor. So removing financial barriers to care is one way to address one problem that is a contributing factor to health disparities. So we started with type 2 diabetes. And we essentially said zero cost sharing for type 2 diabetes. So no copays, no deductibles, no coinsurance for many services that type 2 diabetic patients need, including your doctor's visits, your lab work, eye and foot exams annually, your supplies, your insulin is free. This year, we added pediatric mental health. We heard from Children's National as we were doing our work on equity that there's a significant risk of DC losing an entire generation of Black and brown kids. Pandemic-related isolation, vicarious trauma, and other factors contributing to additional needs for pediatric and behavioral health services. So starting last month, essentially your office visits, including specialists, medication, lab work, $5 copays, that's it. No deductibles, no coinsurance. And that makes a big difference if you can afford to take your child to see a psychiatrist or not. And more recently, and this benefit will kick in next year, we've added heart disease and stroke to no cost sharing for outpatient care. And that includes seeing your internal medicine doctor, getting generic prescription medication, lab work, imaging, including CT scans, which often can be cost prohibitive. So no cost sharing for those services. And heart disease is a leading cause of death nationally for Black Americans. And so starting next year, those outpatient services will be without cost sharing. The other important work that we're doing on equity is looking at institutionalized racism. And what I mean by that is clinical guidelines that embed discrimination in the way the guideline works. So even if you get yourself to the doctor, it matters how you're treated, and it matters whether the clinical diagnostic tool being used disadvantages you automatically because the color of your skin. And one area we're focusing on is EGFR, which the clinical guideline was in fact updated, but the problem is that not all labs have updated their formula. EGFR measures your kidney function, and under the old formula, your score gets adjusted upward if you are Black. And that means the dosing for your condition is not correct. It means you may not qualify for a kidney transplant because it's too late. And so the work that we're doing around this is focused on figuring out how we can help and amplify all the advocates that are working to change how labs apply their EGFR calculation. And the areas that we've identified as a big challenge is not all labs are aware of the new standard. IT costs are sometimes prohibitive for some labs, and smaller labs lack resources. And so our focus is raising awareness among labs to get the EGFR updated to eliminate the race adjustment. I see I am way out of time, so I just want to say how appreciative I am of the additional time you have given me. And I'll conclude by saying we have always been a leader from day one. We continue to lead, and I look forward to your questions.
Thank you, Ms. Kaufman. And thank you to the entire HBX team in terms of the work that you do. I don't know how often you all get thanks. So let me start there before we get into the oversight piece of things. I do have some questions, not a lot. We'll get into it. We'll have a conversation, and then you'll be on your way before lunch. Maybe. So I want to start with so there were a couple of individuals who testified today about the sister grants that you provide. HBX awarded about $684,000 in sister grants in FY23 to a number of organizations to help people transition who are no longer eligible for Medicaid and to get on the exchange. So this is part of the unwinding that has been going on. Is it accurate in terms of the pre-hearing responses that we received that the assisters only actually enrolled 6 individuals in DC HealthLink?
So I'd like to clarify the responses we provided.
Great.
So our sisters do a lot of things for us. And so they, for example, they do all of our open enrollment events. They, Carlos Rosario One Touch, our sisters staff them. They, even outside of open enrollment, they work on special initiatives like healthcare for childcare. This most recent special initiative that we have, of course, is Medicaid unwinding and catching people. So our sisters do open enrollment, outreach throughout the year, healthcare for childcare, and Medicaid unwinding, helping us with all of those things. In the past, our sisters have, we've used them, for instance, during the pandemic when lots of businesses were closing their doors. Those businesses insured through us, we had our sisters reach out to them to see if we can get their workers who were DC residents enrolled into DC HealthLink. So the more accurate picture about our sisters
is the totality of the healthcare for childcare and
they are the army on the ground for us. They are our troops, and we absolutely rely on them for everything.
Okay, because it seemed to us in reading it that the grants were only provided for this unwinding purpose, and 6 to me seems small, given all that we're seeing happening on the healthcare finance side. Okay, that's helpful as a clarification.
And we'll revise next year to make sure it's clear.
Great. Let's talk about healthcare for childcare, which I said at the top, I think is one of those sort of, as a legislator, joyous kind of moments of it's something we thought about. We heard from advocates of something they wanted. We put it in, and then you actually see the outcomes of it in such a short period of time. If we think about when you all launched to now, how many people have enrolled, how many people are talking about it, and sort of sustaining from there. You all received CARES Act funding through OSSI in FY23 and FY24 for 3 FTEs to support the implementation of this program. How are we going to fund these positions in the future, given that CARES Act funding is going away?
So we have an MOU with OSSI to fund the 3 positions, and essentially, if there's no future funding available, we will absorb those costs. And I just want to clarify, we have more than 3 people who work on healthcare for childcare.
Oh, yes, I know.
We appreciate the amount that we do receive from OSSI through the MOU, but we're fully prepared to continue the level of effort and outreach and enrollment, even if in the future years there's no funding for those 3 positions.
According to your pre-hearing responses, you all requested that healthcare finance hold off on Medicaid redetermination for the 1,000 Medicaid enrollees who are employees of OSSI licensed childcare facilities until April of 2024, so that you can conduct outreach to those individuals in February. Why did you ask for the redeterminations to be paused?
For a number of reasons. One of the things we heard from advocates in the healthcare, in the OSSI community, is lots of changes, big changes, like with the wage supplement, for example, was a lot. to take in, right? Because for years, there was no income, supplemental income. There was no healthcare for childcare. So lots of changes. And so we wanted to simplify things. Number one. Number two, we were worried about the churn, right? When people are no longer eligible for Medicaid and we have to get them into something else that they are eligible for. So it made sense to us since we knew everyone who is eligible for healthcare for childcare through OSSI and also had Medicaid coverage. It made sense to us to work with DC's Medicaid program and have that set of people redetermined as part of the last group that DC Medicaid is redetermining.
Okay.
And that actually freed up some of our resources as well to focus on the general Medicaid unwind population. And so what it means now is we can individually monitor each person whose Medicaid is being redetermined, who is eligible for healthcare for childcare if they lose Medicaid. We can track their progress through redetermination. And if they no longer qualify for Medicaid, we can switch them into healthcare for childcare.
Okay. So this was an effort to make it a much more seamless transition.
Yes.
And lessen ease the workload burden as you all are sort of working through that process.
Yes. And we are sending emails to all of those people that we have on our list.
Okay.
I think it's over 1,000 people or so, letting them know to expect a notice from DC Medicaid. And we'll be tracking the progress. If there's outstanding verification that's necessary, we will be following up. And once there is a redetermination that's made in April, if someone no longer qualifies, then we'll quickly get them into healthcare for childcare.
Okay. And just for clarifying for the public purposes, it's only, we are not pulling someone off Medicaid to join healthcare for childcare. It's only if you're ineligible for income reasons, et cetera, that we would then offer this different type of insurance.
Yes. And in fact, our outreach efforts, when we talk to healthcare for childcare eligible workforce, we first look to see if they qualify for Medicaid, because if they do, that has no financial out-of-pocket expenses.
Correct.
Pretty much. And that is the program that someone should be in if they qualify. So we help them get enrolled. If they don't qualify for Medicaid, then we enroll them into healthcare for childcare.
Okay. One of the things that you mentioned in terms of a change for healthcare for childcare for this past year was automatically shifting folks from silver to gold coverage. How much additional did that cost, that modification that you all made?
In terms of the premiums that we're paying?
Yes.
I'll have to get back to you, but I don't have the number at my fingertips.
Okay. Because I'm sort of, this is great. Yes. For the consumer, I'm thinking about it from the perspective of the pot of money that you have in the fund, and making sure we are not, well, if we are going to run through that more quickly, then we need to recalibrate the agreement with OSSI to ensure that coverage be able to sustain.
We've been very conservative.
Okay.
And we also don't like to spend more than what we have, as you know.
That's great.
And we are confident that we are not going to be over the allotted amount.
Okay. And in terms of the feedback that you got, that was the impetus for the switch. I mean, obviously from a numbers perspective, it makes sense to me to go to the gold coverage because it's a lower deductible, a lower amount in terms of cost sharing. Was that something you guys were hearing from the advocates as you were implementing the program in the first year?
Yes, we talked to not only advocates, but workers and employers, and they were hesitant to enroll, some of them, because the deductibles were so high. Now, those standard plans, there is no deductible for essential care, like specialist visits, primary care visits, urgent care, generic prescription drugs. but the deductible does apply to everything else. So that in combination with the fact that in our first year, we just didn't know what the take-up rate would be, and we wanted to be conservative. We didn't, at the staff level, we didn't like the silver plan for this population. We didn't think it was a way to improve access to affordable care because of the deductibles. But we wanted to be conservative, and based on our initial enrollment and the feedback from advocates and the feedback from actual workers and employers, we decided absolutely, let's move to gold, and and there's enough funding to make sure that everyone who wants to participate can and get the gold level coverage.
Great. Shifting from just talking about healthcare to childcare, but talking more generally. So starting in 2024, standard plans for pediatric behavioral health services only includes a $5 copay with no deductible. I know it's only February, but have you received any feedback from beneficiaries about this particular change?
So we typically don't get feedback
Okay.
unless people have a problem, and then we help them.
Yes.
We always welcome feedback. We made this change to ensure that cost is no longer a barrier to getting your child the kind of mental health services your child needs.
Are there any concerns about there being an adequate number of providers to meet the need?
So that was one of the issues and challenges that was discussed in our work. And what our stakeholder working group wanted to do was let's tackle the problem that we can tackle right away and have a longer term effort and work with others who are leading the way on, for instance, network adequacy and provider issues. Children's National was they helped us tremendously with the coverage design on pediatric mental health. And we know that they're engaged in significant work on this area. And network adequacy, I'll say, is having enough providers in this area and others is not only a challenge in DC, but nationwide.
Oh, yeah. And I wouldn't say that it is you all's responsibility. That's a workforce question that we have across the board. But I do have a follow-up on this. So we heard from a resident who is insured through DC HealthLink Small Business Exchange. Her plan is with Blue Cross. Her child has a weekly behavioral health appointment at Children's National Clinic, which has now started charging her a $50 facility charge for every visit on top of her copay, even though her plan prohibits facility fees. When she asked about it, Children's said, well, we could switch you to telehealth if you want to avoid the charge, but she obviously believes that that would decrease the effectiveness of this pediatric service for her young person. She reached out to you all, and the agency said that there wasn't anything that you can do here, but how does Health Benefit Exchange work with insurers to make sure that they're enforcing their contracts with providers? We have it that it says no facility fee, and yet she's being charged the facility fee. So can't even fully take advantage of the $5 copay, which is great because now it's a $55 fee altogether.
Yeah. So this is the first time I'm hearing about this case, and I would like the opportunity to look into it further and investigate.
Okay.
We're not perfect. Sometimes our team has the right answer. Other times we give an incorrect answer. I don't know in this case. So I'd like to take a look at it.
Okay, great.
We also, so usually when there are certain charges, they're not unique to DC HealthLink coverage. It's market wide to any private payer. And so in some of those instances, we do work very closely with DSB because they have oversight over the entire insurance market to see what's happening. But let us take a look at that particular case and see.
We'll follow up with you guys so you can have the further details. Frankly, when I sort of hearing about this, it reminds me of this other conversation that we're having in the restaurant side around additional fees being added on. And then an additional conversation is having on the business side around concert fees. So in general, just the sort of surprising nature of it, I think, is also the challenge, right? You think that, okay, I'm going in with a $5 copay, and then they're like, actually, no, there's another fee that you didn't know anything about. And I want us to try to minimize that as much as we can. So we'll follow up with you on that.
Yeah, and if I can just add, for us, if someone is adding on additional fees to make the $5 copay meaningless, that is a violation of our standard.
Right.
And so I don't care what you call it. If it's not $5, then it's likely a violation of our standard. That's why I'd like to take a look at this case.
Okay, great.
closely.
Let's follow up on that one. Since 2013, you all have offered no cost sharing for diabetes, or medical care related to type 2 diabetes, which I think is fantastic.
Since last year.
Yes, since 2023. Sorry, can't remember what.
10 years ago.
Oh, apologies. Okay. This is fantastic for so many people. We had our performance oversight hearing with the United Medical Center, and they talked about for something like 40% of their admissions at UMC all have diabetes that they see. After a year of this, have you all evaluated to look at increased utilization or other metrics to see if this was impactful?
Our equity recommendations included a commitment from all of our insurers to do their own evaluations. So we weren't prescriptive in how they were going to do it or what they were going to do. We just asked them to evaluate, because we also would like to understand whether this equity-based benefit design over time gets you what you're looking for.
Right.
So the goals here are for you to actually get your insulin when you need it, to monitor the blood sugar level, to figure out if you're dosing correctly. And so we did ask our insurer partners to evaluate. More recently, we have a consultant we are starting to work with to work with each insurer to see what they're actually doing to monitor this.
So wait, you guys asked for the insurance companies to do their own evaluation. Do they not have to provide that documentation to you all?
They do, but it takes time to do evaluations.
Right.
And so, and it may take years to actually figure out whether, what utilization has gone up and perhaps outcomes of that higher utilization. I'd like to see things quickly, but in evaluating access to care and what difference that makes, unfortunately, it takes a minute. But the purpose of one of the goals behind getting an expert clinical consultant is to dig deeper into what each carrier is actually doing to figure out if there's any preliminary themes that the carriers are seeing.
That would be helpful. Or do you have this requirement for all of the types of things that you guys have changed in the name of equity?
For our standard plans.
For standard plans, yeah.
For the equity-based benefit design.
Yep.
So the carriers will be are looking at type 2 diabetes, and then they also have to look at pediatric mental health. So for every benefit that we're changing, we're going to want information on what that results in. On type 2 diabetes, there's lots of literature out there. There have been studies done how investing in managing type 2 diabetes actually has long-term savings and has positive implicates positive in a positive way for your health and well-being. There isn't as much literature in other areas, and so we've essentially asked the carriers to
help develop that.
Exactly.
Yep. In terms of the coverage expansion on type 2 diabetes, did that also include new technology around insulin pumps and continuous glucose monitors?
Yes, we verified that with 3 out of the 4 carriers.
Okay.
We're still waiting on information from one other carrier, but the answer is yes.
Great. The more I read about them, especially the continuous glucose monitors, it just makes sense to me in that it takes some of the guesswork out in the previous type of thing, right? Because, it'll send you an alert to your phone and say, hey, your numbers are not where they need to be. In terms of the equity-based model, you also mentioned in your pre-hearing responses that you plan to implement no cost sharing for cardiovascular and cerebrovascular disease medical services starting in 2025. This seems broader than some of the other things that you all have done before. So, cardiovascular medical services can be any number of things. Have you received any pushback about this change from the insurance companies?
Our insurance companies were all of them served as members of our social justice working group. And that was a consensus-based recommendation. The facilitator for the social justice working group, by the way, it was chaired by our board chair, Diane Lewis, and it had two other board members, Tamara Watkins and Commissioner Woods, as members. It also had advocates and the DC Hospital Association and physician groups, patient advocacy groups, and all the carriers and brokers. And our facilitator, Dr. Dora Hughes, at the time she was at GW, now she's with the Biden administration, but she and her staff helped identify which conditions in DC specifically disproportionately impact communities of color. And type 2 diabetes was very prevalent and disproportionately impacting communities of color. So we started with that. Then we went to pediatric mental health. And the third for DC was heart disease and stroke.
Yeah.
And so the details, of course, are the details of what is covered is clinically and data driven.
Okay.
So we use our standard plans working group to develop what that coverage looks like. And in those recent discussions, there was a robust conversation about making sure that outpatient services are covered.
Okay.
So your outpatient services from internists, internal medicine, family medicine. So if you go see a cardiologist, that's not zero cost sharing. You're going to have a specialist copay there.
That's helpful to have some specificity to it, because just reading it, I was like, that could cover a lot of things, especially when we think about the number of DC residents who have heart disease, or are dealing with some of the aftermaths of a stroke, or something to that effect.
Yes. So what that benefit will cover next year is your visits to your family doctor, internal medicine doctor, your generic prescription medication that you need to manage heart disease, for example, your lab work, imaging, all of that will be no deductible, no cost sharing at all. So no copays, no co-insurance. But if you have a heart attack and you're in the hospital, that is regular cost sharing will apply to that.
Okay. So last year, the council passed the Prior Authorization Reform Amendment Act of 2023, which establishes prior authorization guidelines and requirements that health insurers must follow. It is currently in effect for private insurers. We're still got to pay for it for the Medicaid side, but how are you all working with providers under the DC Health Link to ensure that they know what the legal requirements are?
Though all the laws that you passed or pass, our insurance companies have to comply with, and because the standards are not unique to DC Health Link, the standards have to be applied in a uniform way. And it's the insurance department here that's responsible for making sure that the insurance standards are complied with market-wide. I'm not aware that we've received any complaints, but if we do get complaints in areas that are market-wide standards, our approach is to refer those issues to our sister agency, the insurance department. And the
Okay.
insurance department has broad authority, and they can look at market-wide, patterns, practices,
Right.
and address those.
Okay. In the same vein, we were busy last year. We also passed the Copay Accumulator Amendment Act of 2023, which requires health insurers to apply discounts, product vouchers, and other reductions in out-of-pocket expenses made by or on behalf of a member when calculating a member's cost-sharing requirements. I guess a better question is, when there are changes like this, does DC HealthLink also send out a notification to providers, or do we rely on DSB to send out those insurance or the updated, and now this is going to be required of insurance companies notices? I don't even know what we call them.
Anything that's market-wide,
Okay.
we really rely on the insurance regulators. But sometimes we get consumer complaints. And when I say consumer complaints, I mean a physician's office can call as well. And so we do make sure that we share all of that with the insurance department.
Okay. Now there is one bill that we passed that is has a unique application to you all. So the council passed the Expanding Access to Fertility Treatment and Amendment Act of 2023 last year. It includes a fiscal impact statement that estimates the defrayal cost for plans under DC HealthLink. So we were able to do it no problem for private insurers. But given the ACA and all of its great glory, but it is also a barrier right now in doing this, says you have to cover the defrayal costs for plans. Since then, CMS has proposed regulations that will allow for DC HealthLink to cover the additional health benefits without the defrayal costs. Do we know when those rules might become final?
No.
Okay.
Based on past similar proposals, I expect them to become final sometime this spring.
Which is too late.
Well,
for our purposes.
For DC HealthLink, the forms and rates, so the policies and the proposed premium rates are usually filed on May 1 with the insurance department. There is, a small opportunity in the summer to make tweaks, but they can't really be major coverage design changes. And I just want to clarify, so the proposed federal regulation would allow states to choose a different, essentially essential health benefits benchmark plan.
Correct.
Which in our case, the decision is with the insurance regulators in consultation with us. That's how we've done it in the past. But that step needs to be taken, assuming the federal government finalizes the standard as proposed.
Okay.
That's the other piece that would need to happen.
Okay. So if I think about that, if I'm doing timeline, so we say maybe CMS in the spring, but then there has to be a consultation period between you guys and DSB in terms of what is the new essential health benefit or essential health services package plan, our new standard.
Benchmark.
So this new coverage for fertility treatment is supposed to go into effect of January 1 of 2025. So we DC government would at least need to cover the deferral costs for 1 year, because there's no way that all of these different pieces could happen in time for a May 1st submission by the insurance companies. Yes.
Yes, and just one addition. So the actual benefit package, you've empowered DSB to provide guidance on what that looks like, right? And so those details also need to be worked through. So insurance companies know what they must cover under the new requirements. So all of those things need to happen, and we're prepared to support our sister agency as much as they need us to.
Okay.
Um,
Okay. I'm speaking with the hopes because at the time that all of this is happening, we're going to have an entire private insurance market that has already moved forward, and or insurance market of, sorry, you also do private insurance. So private insurance market of plans outside of the exchange that on January 1 will already move forward. And then already of January 1 of this year, we already have the changes that we made on Medicaid has already moved forward. So my fear and my concern is that I have my folks on the exchange who are just kind of out here on an island. And I don't want to keep them out here on an island, especially when I think about a number of the people who are on the exchange are on the other side of Pennsylvania Avenue with too much power. And I'd like for them to have the same type of insurance company coverage that everybody else is having as well. And so what we have done, DISB, DISB has put out for actuarial study for specifically for this coverage. It's supposed to be, I talked to Commissioner Woods, it's going to be finalized in March. So that'll give us what we need. Hopefully it's very close to the estimate of what we already have. And then if we were to include the deferral costs funding for HBX in the FY 2025 budget, which, as you know, passes in June, is that enough time?
So we can implement, as you know, we have a long history of implementing things and new initiatives very quickly.
Okay.
So we're not going to be an obstacle, and we're going to focus our priorities to make sure we implement any kind of payment we would have to make to carriers very quickly.
Okay, great. So you provided, well, first off, happy birthday to the DC Health Link, 10-year anniversary. Unfortunately, even 10 years later, we still continue, as you noted in your testimony, to see challenges of people trying to essentially roll back something that folks have had for a decade now. And you know, I think we could see probably some federal challenges to the ACA as well as state marketplaces after the 2024 election. Could you underscore, you know, what you see as the importance of the protections that we already have in place?
The Affordable Care Act did a lot of things. It set fair rules for private insurance, so people can no longer be told, no, they look the wrong way, they live in the wrong place, they're the wrong gender to get coverage. So the Affordable Care Act has made a big difference in terms of our rights as health insurance consumers. It protects us and it saves lives. And DC was a leader and early adopter. But if it's repealed, no state could make up for the financial resources the ACA gives to people to afford health insurance. The APTC, the monthly tax credits that make premiums lower. No state can make up for any loss of that, of course. And you know, the Medicaid expansion that has occurred, which is a large part of the reason why so many states have cut their uninsured rates substantially. It's both private market consumer protections as well as the Medicaid expansion piece. Last go around, I think it was 2017, when there was a concerted effort to repeal the ACA. All of our community partners, insurance companies, physicians, hospitals, advocates, we've all partnered to successfully defend the ACA. In fact, all you and other leaders, elected officials, and Mayor Bowser were strong advocates, and not only calls to the Hill and lobbying individual offices, but you and other policymakers made sure that we all were successful at defending the Affordable Care Act. But to your question, if it's repealed, lots of people could be in danger of losing what they have, which is affordable health care.
Yeah. Hopefully everybody does their part to make sure that doesn't happen. I have two more questions for you. So one, in terms of the success of healthcare for childcare, we've been thinking about another industry that faces similar challenges on the workforce side of things, home health agencies. Are there any home health agencies that currently get their insurance through the exchange?
Even if I knew the answer, I could not tell you. They would have to tell you themselves. We don't, we
okay.
usually, unless someone says they're covered, we usually don't give out that information.
Okay. If uh if someone wanted to set up a system similar to healthcare for childcare for another industry of workers, how would they go about doing that?
We would essentially approach it in a very similar fashion that we approached early child development sector. We could implement anything and everything essentially. We would leverage DC Health Link. Folks would have access to the same exact policies and options that everyone else has. And the premium that they would see would just be free or lower, depending on how much funding is available.
Okay. It's not ready for full prime time, but I'm thinking about, we have a hearing in March around direct care service workers. So home health aides, certified nurse assistants, et cetera. Every time I talk to someone in the long-term care space, they're talking about the workforce challenges that they're having of recruiting people, retaining folks, and in hearing some of the public witnesses who testified who were like, no, this is a recruitment tool. This is a retention tool. Even, I think her name is Miss Rock, who testified, who said, I wouldn't have been able to do this for myself and my daughter without this. It could be a way for us to think a little bit outside of the box with this particular group of workforce. Although I want to think about it a little bit more because right now, it's such a transient population that we'll have to see if it could work. So let's talk more. One final question I wanted to ask you. So we're heading into, this is the committee's last performance oversight hearing. And we're heading into the budget cycle. Based on the documents that you all provided us, it indicates that HBX in FY23 has a budget surplus of about $17.8 million. I understand that this is an inaccurate figure because you all operate on different fiscal calendars, but I want to give you an opportunity for the record and to speak on this because there's some people who are going to be reviewing the the pre-hearing responses that we put online and think that, oh my gosh, you guys are flush with cash. Or that you didn't spend everything that you were supposed to spend and not recognize that your agency is a bit unique. So what fiscal year do you all operate on?
So we are on the district fiscal year.
Okay.
And what we don't usually embed in our budget is IT development cost. We have a 3-year IT roadmap that's evergreen, essentially. And so what we don't spend, maybe we have a cost savings from not filling positions quickly enough, for example, we fund IT development with. And if we don't have enough money for IT development or for everything that we want to do in IT development, we just dial it back. We typically don't put IT development in our budget because we'd rather not include that in our assessment. Our operating budget is funded through an assessment on all health carriers. And for the most part, that's just a pass through. And so we know every dollar higher in premiums could be someone not getting insured, right? So we'd rather keep our assessment as low as possible and fund IT development with, interest that we earn or any other savings that we get. Sometimes we get federal grants. Other times we get savings like the 3 positions you mentioned that Aussie is funding to help us operate healthcare for childcare. And so anything that you're seeing extra is our, for the most part, our 3-year IT development roadmap.
Okay. All right. Well, I don't have any further questions for you at this time. We have 2 follow-ups. So, first, how enrollment has changed from the switch from silver to gold plans, but also the cost differential, Benny. And then we'll follow up with you on the residents' concern about the children's facility fee, because if children's is doing it, somebody else might be as well. And thank you. Is there anything else you wanted to say that I haven't asked you?
Nope, just really appreciate the 10 years and your strong support for us and the ACA. So thank you. And a huge, I want to acknowledge my team. None of this, we wouldn't be here sitting successfully before you testifying if it wasn't for the incredible team that we have and the full support that we have from our executive board as well as the mayor.
Great. Well, thank you so much. So we're going to turn to our health licensing boards, but we're going to take a 6-minute break so that my staff can stretch their legs. And then we'll be back in 6 minutes. Thank you. Okay, and we're back for our health licensing boards. DC Health currently oversees 19 health professional licensing boards, which support the licensure, renewals, investigations, and disciplinary hearings for over 107,000 health professionals in the district. Since I became chair of this committee last year, we have conducted oversight hearings on 10 of these boards, and today we will hear from 3 additional boards, as well as bring one back for its second oversight hearing. I will now describe the scopes of the 4 licensing boards and then turn it over to their board chairs for testimony and questions. The Board of Nursing is responsible for the licensure and regulation of approximately 52,000 registered RNs, licensed practical nurses, advanced practical registered nurse, nursing assistive personnel, certified nursing assistants, home health aides. The board has 11 members appointed by the mayor. 7 must be registered nurses licensed and practicing in the district. 2 must be practical nurses licensed and practicing in the district, and 2 must be consumer members. The Board of Dietetics and Nutrition regulates the practice of dietetics and nutrition for 569 dietitians and 64 nutritionists registered in the district. The board consists of 5 members appointed by the mayor, including 4 licensed dietitians or licensed nutritionists and 1 consumer member. The Board of Massage Therapy regulates the practice of massage therapy for 632 massage therapists licensed in the district. The board consists of 5 members appointed by the mayor, including 4 massage licensed therapists in the district and 1 consumer member. And the Board of Veterinary Medicine regulates the practice of veterinarians, veterinary technicians, and veterinary euthanasia technicians in the District of Columbia. And they advise the mayor with respect to the regulation for veterinary facilities. The board consists of 5 members appointed by the mayor, including 3 licensed veterinarians, 1 vet tech, and 1 consumer member. I'm going to now turn to Dr. Deanna Nara, who is the chair of the Board of Dietetics and Nutrition. Before you begin, I need to swear you in. So if you raise your right hand, so it can be seen in the camera. Do you swear or affirm on a penalty of law that the testimony you're about to provide to the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth?
I do.
Great. Please begin.
Good morning, Chairwoman Henderson, members of the Committee on Health, and staff. My name is Dr. Deanna Nara, and I have the honor of serving as chair of the District of Columbia's Board of Dietetics and Nutrition. On behalf of Mayor Muriel Bowser and DC Health Director Dr. Ayanna Bennett, I am pleased to provide this testimony on the Board of Dietetics and Nutrition's activities and overall performance in fiscal years 2023 and 2024 to date. I have served on the Board of Dietetics and Nutrition for over 4 years, having been appointed in 2019. I was subsequently appointed as chair of the board in 2023. Prior to my appointment on the board, I served as an expert advisor on the Board of Dietetics and Nutrition subcommittee to inform updates to the district's regulations. I have been a licensed nutritionist in the District of Columbia since 2013, and I'm currently a senior policy associate at the Center for Science in the Public Interest. Prior to that role, I had the pleasure of directly serving district residents as the nutrition program director for a community-based provider that offers meals across the district. Additionally, I have worked to advance the nutrition profession as a teaching assistant at Howard University's Department of Nutritional Sciences. I have been involved in the nutrition profession for 10 years, having earned a master's in botanical and culinary medicine from Maryland University of Integrative Health and a doctor of philosophy in nutritional sciences from Howard University. The Board of Dietetics and Nutrition is one of 19 health professional licensing boards within the District of Columbia. It is responsible for licensing dietitians and nutritionists through the review of applications for licensure, investigation of complaints, and administering disciplinary action, and it maintains the standards and procedures for the profession. The board consists of 5 members, 4 of whom are either licensed dietitians or nutritionists, and 1 is a consumer member. The board meets on a quarterly basis and is supported by an executive director, board attorney, and health licensing specialist who support the operational needs of the board. As of February 2024, the board licenses 589 dietitians, 64 nutritionists. These numbers have remained consistent over the past 5 years, with the number of licensed dietitians increasing by 3.4% and the number of licensed nutritionists decreasing by 5.9%. Dietitians and nutritionists play an important role in advancing the overall overall health and wellness of district residents. Notably, the services they provide are essential to preventing many of the leading causes of death in the district, including heart disease, diabetes, and hypertension. Licensed dietitians and nutritionists serve some of the most vulnerable populations across the district, including children, seniors, and people with chronic health conditions and disabilities. Many of these professionals serve patients at hospitals, long-term care facilities, schools, federally qualified health centers, and other community-based organizations. The district has 2 universities, including the University of District of Columbia, that are preparing future dietitians and nutritionists. Overall, I am proud of the work that the Board of Dietetics and Nutrition has undertaken to ensure this important element of the healthcare workforce remains robust. The Board of Dietetics and Nutrition has worked on several important initiatives over the past year. To improve the efficiency of the licensure process, the board changed its policy to no longer require applicants to submit their college transcripts, assuming that they are certified by either the Board of Certification of Nutrition Specialists, CNS, or the Commission on Dietetics Registration, which is CDR. These 2 nationally recognized organizations verify that applicants meet the relevant educational, experience, and training requirements. This decision by the Board of Dietetics and Nutrition has streamlined the application process by reducing the timeline for applications, as transcripts are no longer needed to be physically received, and reducing the cost to applicants. The board is also proud of the efforts that have been undertaken to modernize the practice of dietetics and nutrition through the Health Occupations Revision General Amendment Act of 2023. This legislation updates the scope of practice for dietetics and nutrition, as well as combining the 2 existing licenses under the authority of this board into 1 dietitianist nutritionist license. I look forward to working with my fellow board members and professional community to advance these changes should they become law. On behalf of my fellow Board of Dietetics and Nutrition members, thank you to the committee and the entire council for your continued support of the district's healthcare workforce. I appreciate your time and this opportunity to testify before the Committee on Health, and I look forward to any questions you may have for me at this time.
Thank you. Thank you so much for being here. I just have a few questions for you. So in FY23, it took an average of 36 days for a dietitian application to be approved and 33 days for a nutritionist application. In your experience on the board, is that considered normal or longer than usual?
That is considered normal.
Okay. And do you feel as though the board has sufficient staff support and resources to expeditiously review and process applications?
Absolutely.
Right. According to the pre-hearing responses that you all submitted the committee, there was a noticeable shift in approval rates for dietitian license applications between FY23 and FY24. Specifically, only 37.5% of the 312 applicants were approved, whereas so far in FY24, 87% of the 371 applications were approved. Similarly, it was a lower approval rate for nutritionists back in FY23 in comparison to where we are right now in FY24. What factors contributed to this increased rate of approvals?
It's hard for me to maybe assimilate a direct cause. If there were certain things that created this change, I'm not specifically sure which exactly.
Okay. Were there any changes? Oh, sorry.
Yes, that's what I was about to say. The criminal background check process was changed. So that could definitely be one of the pieces that would have made that change.
Can you just specify for the record so people kind of know what we're talking about in terms of what was the change with the criminal background checks over those 2 years?
Sure. I know that the process for the criminal background check was changed.
Okay. Did the board?
Sorry,
Okay.
it specifically required renewal. That had to be done.
Sorry, say that again.
During the renewal period for licensure, they had to submit a criminal background check, which was something that was a newer policy that was enforced.
Right. But that might have thought would have slowed things down. You all just went to approving more people in FY24 overall. And so I'm wondering, is it you all are receiving incomplete applications or you were receiving incomplete applications or individuals who hadn't met all of the qualifications in FY23 and you guys were just clearer in terms of your requirements? That's what I'm sort of referring to.
Yes, that is the case. That is absolutely part of the case. And we do also just in the process, the application process is applicants submit their application and supporting documentation through this Salesforce online platform. Applications are reviewed by the board staff within 3 days. When there are incomplete applications, which includes missing verification of licensure in another jurisdiction, transcripts, or criminal background checks, applicants will receive an email from board staff outlining what they're missing. Applicants then have 120 days to submit that missing documentation. So I think that we've just really improved efficiency on the DC Health side, resulting in more licensure.
Okay. Does the board have a particular stance regarding, so the committee currently has a bill before us, the Health Occupations Revisions General Amendment Act of 2023, which there's a provision in there to merge dietetic and nutrition licensure into a single license. Does the board have a particular stance on that, considering you have both dietetics and nutritionists who are currently serving?
We do. And as the board, we do believe that the one licensure approach will allow nutrition professionals to better serve the residents of DC, improving access to much needed nutrition care in the district by highly trained practitioners. We know that providing nutrition care can reduce chronic disease suffering, healthcare costs, and healthcare disparities. And we also know that this is not, the merging of these licenses is not something that is new. This is something that has been taking place across the country in several states, Maryland being our most closest neighbor, who also has merged licensure.
Okay. Are there any distinctions in terms or any substantial distinctions in terms of education or training though? Like you mentioned, I think you mentioned in your testimony, 2 universities who have programs here.
Correct.
Are there coursework differences? I think maybe even, it might be helpful in terms of like, what is the distinction between a dietetic versus a nutritionist?
So most recently, the biggest change, previously before 2024, dietitians were only required to have a bachelor's degree, where nutritionists were required to actually have a master's degree. That changed in January 2024 of this year, where dietitians moving forward for licensure are required to have a master's. And so now they are even more aligned, which supports our one licensure policy change or a submission to the HORA. The specific educational and examination requirements come from one of 2 pathways. So it either is you're entering with your degree or generally in specific areas, so human nutrition, food systems management, dietetics, etc. And then within those particular pathways, in the dietetics pathway, they have to complete certification examination through CDR. If you're on the nutritionist pathway, similar. So they have to successfully complete a certification examination for nutritionists, and that goes through the BCNS, which is the Board of Certified Nutrition Specialists. And the other piece is a certification examination for a diplomat of the American Clinical Board of Nutrition. And those are the pathways. Within those 2 pathways, though, there are 900 clinical hours that are required. So both of those are going to have extremely similar, if not very streamlined, coursework, as well as requirement for clinical hours supervised by either registered dietitians or nutritionists.
Okay. And so there's no concern with, well, I assume since your board is together anyway.
Yes.
Is this a profession? Are these professions that are often people interchange the names?
Yes.
Okay.
Yes. Right. I mean, I just adding that, like you said, on our board, we currently have 2 dietitians and 1 nutritionist, which is myself. And we have been working, on these regulations for quite some time with the input of both parties. And we take it very seriously when we think about a change like this, and have worked very hard to make sure that these changes reflect, the movement of the licensure in this country.
That's great. And so, this is interesting. I'll just ask. So for this particular provision in the HORA that came from the board, you guys elevated this up. Okay, great. All right. That is helpful for us to know as we work on that. All right. How are you, or how often does the board interact with the Community Health Administration within DC Health, which leads all of the healthy food access grant programs as well as SNAP education programs? Like, to what extent are you guys going outside of just the let's get folks licensed, but also dealing with sort of the community issues within the DC Health Agency?
So it's generally shared with them.
What is generally shared with them? Sorry.
The licensure.
Right. I understand. You all do licensure. What I'm asking is, do you have other or engage in other types of policy conversations with DC Health around some of its healthy food access grant programs?
Yeah, so as the board, we are board members. We do not participate or generally have opinions. Staff do, but not the board. So unfortunately, as a person who does nutrition policy, I would love to be able to interface more with policy, but staff do have that option and obligation. The board does not.
Okay. That's kind of disheartening to hear, because I feel like you have an expertise level here that could
I would be happy
provide.
to work with you however you see we could work together, for sure.
Yeah. Especially as I think about the growing influence of social media when it comes and misinformation when it comes to nutrition and diet trends, and then some other new forms of diet medications that are now coming online. I feel like you all could be a good source of expertise, and as we're sort of dealing with some of these issues. So I'll ask DC Health more about the engagement front on that part. In terms of your conversations with your fellow providers and licensees, do we find that insurance companies don't really cover nutrition and dietary related services?
Generally, the case is that they do. There is an allotment for so many appointments or visits with dietitians or nutritionists.
Okay. And do you feel like we have enough individuals licensed in the district to meet the demand?
We do. I mean, I think that we can always do more, and we are always encouraging working with, at least I know I personally on outside of the board, work very closely with Howard University's Department of Nutrition and Dietetics to promote dietetics and nutrition students. I teach there. I am always talking to the nutrition and dietetics students and also the public health students, which I think is another piece that is very important. But we do to do as much as we can to promote, because we know that this is only an ever expanding area. And we also know that this particular area actually holds a disparity in practitioners, with over 80% of those practitioners being white. And so to meet the cultural needs of the residents of the District of Columbia, we are always looking to promote and help to further diversity within the workforce, and specifically in dietetics and nutrition.
Okay. The board currently has one vacancy for a licensed dietitian or nutritionist. Do you know if DC Health has submitted a nomination to MODA to fill this position?
I am not aware of one that has been submitted. I know we are doing everything that we can to get someone into that position. We are announcing it at every public meeting. We have advertised it through the website, and I am personally reaching out to private networks of both dietitians and nutritionists in my network of professionals.
All right. Is there anything I haven't asked you that you want to say?
No, I just would look forward to working with you closer on a lot of these other policy pieces.
Yes. I mean, I truly, honestly, I think that, and this is not just for the board of dietetics and nutrition, but I do feel that DC Health has you have like a mini working group, if not that could help on some of these issues around policy. Especially, well, we'll be leaning on you because we've been asked to sort of weigh in on some of these issues, particularly around diet related medications and insurance coverage. And so would love to talk to you guys more to sort of get a better understanding of your thoughts on that, but also the landscape of DC as it relates to providing residents with that type of access. So that's all the questions I have for you. Thank you so much.
Thank you.
We'll go to Meaty Barn Barnelli, who is the chair of the Board of Nursing. Give it a minute as they transition over at DC Health. Here we are. Great. All right. Before you begin your testimony, I do need to swear you in. So if you could just raise your right hand so we can see it in the screen. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth?
I do.
Great. Please begin.
Good morning to you, Chairwoman. Is it morning? Good afternoon, Chairwoman Henderson and members of the Committee on Health and Staff. My name is Meedy Barnelli, and I have the great honor and privilege of serving as the chair of the District of Columbia's Board of Nursing, and also a proud resident and homeowner in Ward 5 here in the District of Columbia. On behalf of Mayor Muriel Bowser and the DC Health Director, Dr. Ayanna Bennett, I am pleased to provide this testimony on the Board of Nursing's activities and overall performance in the fiscal year 2023 and 2024 to date. And I would be remiss if I don't acknowledge my fellow board members, Dr. Cami Cooper, Dr. Rick Garcia, Dr. Patricia Howard Chittims, Laverne Plater, Margaret Green, Tiffany Simmons, and also our own Executive Director, Dr. Terry Walsh, our board attorney, and all the staff that help us make this work get done. I've had the privilege of starting my service with the Board of Nursing back in 2017, and then I quickly moved into the role of interim chair. Following 3 years of serving in that capacity, I was confirmed in 2022 as permanent chair of the Board of Nursing. As chair, I coordinate and lead our bi-monthly meetings to ensure the board is working towards achieving its goals with the focus on equity. As chair of the Board of Nursing, I also serve on the DC Health's Interprofessional Board Chair Collaboration that I'm pleased to say that I was also part of that impetus of making that happen. And this amazing collaboration is made up of chairs of the 7 health professional licensing boards that include nursing, which is number 1, dentistry, medicine, pharmacy, social work, psychology, and professional counseling. We meet on a quarterly basis to enhance our collaboration among health professionals as we are all working to advance the health population here in the district. I also recently just finished a 4-year term on the National Council of State Boards of Nursing Subcommittee for the NCLEX, which is our National Nursing Certification Exam item review committee. And outside of my board service, I also currently serve as a divisional director of nursing at George Washington University Hospital. And prior to that role, I served for 7 years as a director of surgical oncology at the Washington Hospital Center. Additionally, to address the many inequities that we face in healthcare and in our nursing profession, I serve as the president and founder of the Black Nurse Collaborative Incorporated, and I've worked in the nursing field for nearly 20 years after graduating with a bachelor's degree in nursing from the Howard University, and also a master's in nursing administration and leadership from Jacksonville University. The mission of the Board of Nursing is to safeguard our public health and well-being of all district residents by assuring safe, quality care here in DC. This is achieved through the regulation and nursing practice of our educational programs, the licensure, registration, and certification, and continuing education of all of our nursing personnel here in the district. The Board of Nursing has 3 subcommittees. One of them is our educational related, the one is for licensee discipline, and the other is for regulatory review. The board is currently made up of 11 members, of which 7 are registered RNs, 2 are licensed LPNs, and 2 are consumer members. As chair of the board, I am proud that we consistently meet quorum, even with a few vacancies, which have prevented any unnecessary delays in our work, particularly here for nursing. Through the work of these committed board members that I acknowledged earlier and our board staff, we advanced the nursing profession with over 51,000, I repeat, 51,000 licensees over 9 license types. As of February 1st, 2023, the Board of Nursing has licensed 37,293 nurse RNs, 1,629 LPNs, and 10,966 nursing assistant personnel, all here at the Board of Nursing. Those NAPs are a collective name that we use, Councilwoman, for our home health aides, certified nursing aides, trained medication employees, medication aides, dialysis technicians, and patient technicians as well. And we also license over 4,372 APRNs that we call advanced practice registered nurses. As part of our role in protecting the DC Health here and our public safety, we also actively investigate complaints against licensed nursing personnel. In the fiscal year 2023, the Board of Nursing received 63 such complaints. These complaints require a comprehensive review process, including review of legal sufficiency, of which I'm grateful for our board attorney, Pan Ravi Von Ranjat, investigations, hearings, issuance of summary suspensions, and notices of intent to discipline. Additionally, the Board of Nursing is responsible for licensing all of our nursing educational programs. As of 2024, we have 9 schools that offer CNA training, 7 that offer an RN curriculum, registered nurse, and 1 that offers an LPN curriculum, and 3 that offer the home health aide training. This oversight responsibility is extremely critical as we address the ongoing healthcare workforce shortage that is not germane just to the district, that ensures the future generations of nursing professionals so we prepare to serve our district residents. The nursing profession continues to grow within the district despite these challenges. Over the past 5 years, the number of licensed RNs have increased by 28%, and the number of APRNs have increased by 57%. As our current workforce has grown despite the pandemic and its challenges that it has brought nursing, the Board of Nursing has taken several steps to strengthen our profession here and to enhance patient safety, which is paramount, even despite our ongoing shortage. Again, that's not germane just to the district. To increase opportunities to increase the nursing profession, especially our NAPs, the board has added 2 new CNA training providers. The board also has conducted an extensive process to update our APRN regulations, which absolutely was not an easy feat, which will modernize the scope of practice to ensure full practice authority here in the district. These forthcoming regulatory changes will increase access to independent healthcare practitioners within our community. Additionally, the Board of Nursing is collaborating with the Board of Medicine to develop regulations for maternal care professionals here in the district, including certified nurse midwives and certified midwives. I want to make sure that's clear. They're CNMs and certified midwives. As part of our role to protect the public, the Board of Nursing has been working with law enforcement, unfortunately, with information regarding the ongoing Operation Nightingale, which we've all heard about. Unfortunately, this operation resulted in the Department of Justice and the FBI charging 25 defendants in early 2023 for taking part in a horrible scheme to produce fraudulent nursing diplomas. These indictments have implications for the district and our residents, as some of our licensees have received potentially fraudulent diplomas from the affected institutions. However, the Board of Nursing has worked overtime to conduct a thorough investigative process, and we have taken disciplinary action against approximately 30 RNs and LPNs in response to this scheme. While this unfortunate disciplinary process is laborious and ongoing, DC Health, and again, a shout out to all of the DC Board of Nursing staff members who worked on this, has won over 90% of our cases in which these perpetrators, if I might add, of the licensees appealed to reverse their disciplinary action taken by the board. The board has also been working with DC Health's Pharmaceutical Control Division to ensure that APRNs are appropriately registered with the Prescription Drug Monitoring Program that we call PDMP. As a result of our efforts, compliance has increased to approximately 88%, and we are consistently sharing this information during our meetings to get that number even higher. This work is very vital as the board acknowledges the ongoing opioid epidemic that we are facing throughout our country and the importance of responsible prescribers in our community. So on behalf of all those board members that I acknowledged earlier, we thank you and the Committee on Health for your continued support of the best healthcare profession in nursing and the broader healthcare workforce. We appreciate your time so very much in this opportunity to testify, and I look forward to hearing from you, Madam Chair, and any questions you might have for me at this time.
Thank you so much for your service on the board, but also for the partnership that you've had with the committee on other initiatives around wellness. So certainly appreciate you. I have a few questions. I first want to start with the makeup of the board. So my understanding is that among the 11 board positions that you currently have, there are 4 vacancies, 2 for consumers, 1 for a registered nurse, and 1 for a licensed practical nurse.
Correct.
And to your knowledge, has the board or DC Health put forth nominees to the mayor's office for any of these positions?
Yes, ma'am. And we speak about that, Madam Chair, frequently on all of our board members with our executive director, and we work very collaboratively with MODA. And in addition to that, we are waiting to make sure that we have 1 LPN member right now that is currently actively going through that vetting process.
Okay, great. That's good to hear. I'd like to we're making a lot of changes within the Health Occupation Revision Act, but the Board of Nursing is not going anywhere. You have over 50,000 folks that you license, so you're not leaving. So we just want to make sure that you are able to meet quorum each and every time.
And we have. Yes.
Yes, I heard that from your testimony. So that's a great. I wish other boards were as scrappy as you all were in accomplishing that.
Thank you.
So as you're likely aware, DC Health and Children's School Services introduced a new staffing model this year for school health suites. In January, we held a roundtable on this regarding the persistent staffing challenges that Children's has experienced. Has the board discussed this new model or taken a position?
So obviously under oath and very transparently, we discussed it. I think there's always an opportunity, Madam Chair, just regarding the nursing staffing challenge that we currently have. I can speak only for myself that I believe it's great to have a nurse in all of our school buildings. However, we don't have a formal position as a board because we're also monitoring and trying to figure out how to best make sure even all of our acute care facilities and other areas have the appropriate staffing to meet those patients' needs that we have here in the district. So we have not taken a formal stand, no, but yes, we do discuss it and we are aware of those challenges.
Okay. I think one of the things that is often a tension point is, I will hear from DC Health, my hospitals, my nursing homes, anyone else my clinics, my providers saying they have a nurse shortage, which is contributing to some of the staffing challenges that they're having. And then I hear from the nurses union who's like, nope, there's no shortage of nurses. We have more than enough nurses. You're just not paying them enough. Do you all think that there's a shortage? I mean,
so again, I'm speaking for myself as the chair, but not in
for the board.
Let me just say this. The board has not made a formal statement.
Okay.
I can share with you as an individual who's on the board and who has also heard those challenges. We've had a nursing staffing shortage since Florence Nightingale. So it hasn't changed. The problem is that each person has their own particular perception. So I can tell you personally from my own personal work environments, working at several of the larger hospitals here in the district, there absolutely is a nursing shortage. The National Council of State Boards of Nursing also works with the National League of Nursing and the ANA, the American Nursing Association, and it is noted that we do have a nursing shortage. The unions might have a different perspective, specifically only because of, sure, I do believe we should be paid more, but we have to also be fiduciary responsible as it relates to those organizations and how they pay, which leans back into the previous question you asked as it relates to school nursing, right? So what does that pay look like? So you may not have a person who typically comes right out of nursing school. If I might add, again, my personal opinion is I don't think that is the first thing that we're taught to, go to a clinic or necessarily go into a school nurse position. We're always leaned more into that hospital acute care setting.
Interesting. Do you know why that might be? Obviously, that's not you all doing that. And I could probably have this conversation with the schools of nursing, but I'm curious in terms of why is that the natural inclination of a hospital or acute care setting as opposed to a clinic or a private provider?
It's unfortunately, I believe, the culture of nursing. We typically go to nursing school. When you have recruiters, when people come, they typically are recruiting you specifically into hospital settings. And that's, yeah, and it's not, again, not just a district, that's kind of a national situation. When we go to the NCSBN conferences, again, that's typically where most, if you ask any new grad, they're not thinking about going into, community health, or they're not thinking about going into a clinic. And
Interesting.
also hospitals have extreme turnover rates, and we have high vacancy rates. So I'm sure you all would have access, I'm sure at your level, you can speak to, the DC Hospital Association. There are lots of hospital vacancy rates.
Right. Oh, I got vacancy rates all over. So that's why I want everybody to know their options coming out of school, right? Not everybody might be suited to serve in a hospital setting. They might actually be better in a clinical setting or,
you
but
absolutely are correct. Most people make that change. They pretty much come out for about a year or two. I don't really necessarily want to do that. And then they might make a pivot.
Got it. Okay. So in our performance oversight hearing last week for Department of Healthcare Finance, they testified that they cannot move forward on adding certified professional midwives to Medicaid until the Board of Nursing finalizes the regulations. So when do you all expect for those to be finalized?
So I don't have the specific date, but I can make sure that we respond to you. But I do know that our executive director and our attorney, we do have a subset of our board that's working with the Board of Medicine. And so I don't have that exact date, but I know that's actively in the works now. And we can make sure we get back to you with the date as to their meeting dates and when they're going to be able to respond. But that has already happened. The conversation has already begun.
Typically, how long does it take for you all to approve regulations once you have them in draft form?
Typically within 30 days to a month, 30 days to 60, a month to 2 months or so, because it has to go through that regulatory review and it also has to go through the legal sufficiency. And I know that our board attorney works with us on that. I don't have a specific time frame, but it's typically about 2 to 3 months to make sure that happens.
Okay. I want to follow up with DC Health on this because here I have a situation where I have another agency who's ready to move forward, but we can't move forward until your board acts. And so it's like a domino effect, if you will. I don't want us to get in a situation though, where it's taking us 2 or 3 years to actually get this fully over the finish line. Cause it took a lot to actually get it to become law. And now it's this additional step that we need to just go ahead and take care of.
And I will just share, Chairwoman, that it's important to make sure that we literally review that process and that legislation line by line, only because of making sure that we're all on the same page, and particularly considering which I know you are very well aware of, but maternal infant health, we want to expand it. So it's not about creating an additional red tape or barrier, but just really making sure that when it's out, it's good and it's done, and we're not asking to come back to you and others for revisions.
Okay, that's great. So the committee is currently considering a different bill that was introduced last year, Bill 25-430. It's the District of Columbia Nurse Licensure Compact Authorization Act of 2023. How involved has the board been in conversations around even just regional reciprocity agreements with Maryland and Virginia? Go ahead.
So we do not have a formal position as it relates to the compact. I can share, would it be nice? Great. But DC, unfortunately, as you're aware of, again, we're not a formal state. So when you look into what that means, we have to really understand what is the impact on that from a financial perspective, from a regulatory perspective, be considering the number of nurses that we will have to continue to make sure we have that reciprocity with, and that our board staff's able to meet that needs. We are currently working right now with our executive director and our board attorney on a reciprocity with the state of Maryland. We do have a significant, more than half of the nurses that are licensed in the district are Maryland residents.
Okay. Is there a particular reason why we're not looking at Virginia too?
I don't have that specific example. I know that Virginia being a Commonwealth often creates a lot more challenges from legal sufficiency issues. So I think it's just, we have to make sure we have that cross-pollination of ideas and concerns. So I definitely can reach out to our executive director to make sure we have that information. But what I do know is that they're already a part of the compact.
Oh, Virginia is already part of the national licensure complex.
Correct.
Got it. Okay. All right. Well, we'll sort of follow up on that. I think one of the things for folks, for the public, we often get them saying, oh, we need to do this particular compact, and then they'll point to someone who's already done it. So for instance, they'll say, well, we already are in the psych pack. So what's the challenge here? And I have to explain, like, well, at least from my understanding, the Board of Psychology was on board with that move. And so, you know, we all move to get together, or we're trying to sort of move together. So that's why I asked the question around how the board is thinking about the nurse compact, but if not that, reciprocity agreement. So it's good to hear that you guys are currently in process in this conversation with Maryland, given the number of nurses that we have from that area.
And I want to be clear, Madam Chair, that we're not anti the compact. Compacts are great. It's just kind of, it's completely different. And so when you talk about that from nursing, and again, DC not being a state and how that's going to impact, it's a much, much larger conversation.
Yep. Okay. Let's talk about application processing. So you heard, or I'm not sure, did you hear the public witness who testified earlier around her experience of
I was made aware, but I did not hear it personally, but
okay.
I was aware for challenge.
Okay. So when we looked at the pre-hearing responses, the average timeline for a registered nurse application was 44 days. For a nurse anesthetist was 218 days, and the average timeline for a nurse practitioner was 66 days. Now, why do you believe that these applications are taking so long to be processed? Is this a staffing issue? Is it a website issue? Is it a board issue? What's going on?
I will go in reverse. It's definitely not a board issue. What I will share is that a lot of times it's just a volume. So that's why I shared with you, if you heard the 50-some thousand people, and based on the number of staff members that we have here, they do a yeoman's job of making sure. The other part of it with nursing is that a lot of times, and I can speak to this personally, if people obviously know me, will reach out for me to help to expedite, you have to make sure all components, because we're so highly regulated, all components of your application are there. So I do know, having conversations with Dr. Walsh and the other board members, that a lot of the applications that we do receive, unfortunately, are not completed. And then that creates another backlog, because then you have to reach out to them. And then there's another delay because you have to wait from our national warehouse of nurses, right? And they kind of house all nursing licenses to make sure that we have everything. And additionally, there has been a delay over the last few months because of Operation Nightingale. Those investigative conversations, Chairwoman, literally can take 2 to 3 hours. And so for us that are board members, when we come, and the backlog and the information, the investigation from our investigators that do a great job, our board attorney. So if you have just 2 cases, I don't know what they do from a time perspective, but I do know if I'm in that meeting that takes 3 hours, the prep work, I'm sure, takes much longer. So we will acknowledge that.
And I can acknowledge that for some folks, they're not doing their part. The thing that is like most disheartening is the young woman who testified said, no, all my components were there. Then you all said that nobody actually opened up my background check information, and then it expired by the time that somebody decided to click and open it. So that to me is not a user error. That's something that's happening at the board in terms of we're not getting to things in time. Now, given the number of nurses that we have, obviously we put it in buckets, right? You've got new applications over here, you've got renewals over here, and then those are the 2 buckets. And then maybe some people who have like some particular unique circumstance issue where they're trying to, get the reciprocity from another jurisdiction. I guess my question is, should we have everybody renew at the same time?
Well, we currently do that. We will have renewal this year in 2024. We do it every 2 years. The other thing I do want to add.
No, but that's my question. Should we split the baby and say 25,000 of you will go on even years and 25,000 of you will go on odd years?
So I think that we will be looking at that with our overall director to see if we might make that cycle change. And so we are looking at that getting possibly changed. So we are considering rolling renewals to make sure that that can take place. And I will also add, there is room. I do know the board staff, Dr. Walsh and others have heard me say this multiple times. There is an opportunity to help us with our IT as it relates to the actual website. I think there might be a little an opportunity. So I don't know if you can help or make sure there's appropriate allocations, but they did just recently get a new website person. So I'm hoping that with that individual, we will be able to make that process a little more expedited.
Okay. Can you, well, let me ask you if you could do this as the chair of the board and asking the executive director to do this. Some type of audit to make sure that when you have somebody who has all of their pieces in, right? If the background check company's policy is that it's going to expire after 30 days, then it behooves us to get to somebody's application or at least open those documents within the first 30 days. Because it's not fair for the applicant to have to then pay to redo something they already did simply because we didn't get to it on time. And so to the extent that the executive director for the board can go through and check to see, like, I don't know what type of flag that there needs to be, but, if somebody's application has been pending for longer than 30 days, then we gotta do something on our side. And we try on the committee, right? I think we provided some additional staff folks, to the boards to help with the processing piece. But I think maybe then we should think about, okay, if there are too many, if it's too much to do 50,000 at one time, then maybe we need to split the baby or do something different so that it's much more manageable for us to get through.
That's fair. And I definitely think that we will be able to do that. I will just also offer context that it's not just a nursing license that can create a delay. We also have the HHAs and the CNAs, and there's different buckets nationally that hold all of those licenses as we seek, not the licenses, but they're testing that the board staff have to go back and validate and verify. And unfortunately, it is going to be a little bit of a challenge, but we will work diligently because I know sometimes reviewing the criminal background check, they have to make sure that they are qualified first, then we will then do the background check. So you are absolutely correct that it is not fair to them to have to repay, but if the credentials and everything isn't appropriate, unfortunately that will expire. So I'm sure we will absolutely do an audit and be able to report back and maybe ask Dr. Walsh if, considering we're coming up on renewals, mine included, maybe we can see how long does that process take.
Great. So speaking of CNAs and home health aides, the district is experiencing a significant loss in the number of direct care workers in this space. In 2023, about 4,500 less CNAs and home health aides renewed their certifications in October, which was about 30% of the entire workforce. Providers are reporting severe understaffing at many facilities. Are these numbers troubling or surprising to you? I mean, to lose 4,500 people in a year?
Troubling 100%, surprising, no. Very transparently, when you look at how, and the board can't dictate how much we pay these individuals, but if you're living in DC, making only $17 an hour, we've also had very many challenges, Chairwoman, where people have said they were working at two different places, right? So it is a clocking in, and we've had to do disciplinary actions even regarding that. I do know that, and we're grateful that we do have the high needs scholarship, which is over $1 million. And so I know that healthcare career scholarship program is in place. We often also encourage, I know about 2 years ago, we had, I think it was 2 years ago, we had a symposium where we invited all of the CNA schools, HHA schools to come in and have a collaborative conversation with us. Obviously the pandemic was happening, so we need to maybe reconvene that, but I do know that we are working. But yes, it is extremely extremely disturbing and very challenging. And again, would add that we are still seeing a deficit, I can speak to directly, of even patient care techs, even in the hospital settings as well. So unfortunately, that community is definitely suffering for that, but we're doing all that we can to make sure that we encourage people and use this scholarship program to allow to increase that pathway and pipeline.
Great. In March, the committee is going to have a hearing on a bill that I introduced called the Direct Care Worker Amendment Act of 2023. It proposes to consolidate the licenses for CNAs and home health aides and make a couple of other changes. It would be great if the board could submit testimony
Sure.
on that, especially on the licensure piece, because that directly impacts the work that you all are doing. And yeah, that would be great. What was that?
I said, will do.
Okay, great. Wonderful. I want to ask about LPNs. So, oh, hold on. Hang on one second. Okay, so the current board regulations require that licensed practical nursing programs be housed within universities. And we've heard some concerns that that has presented some limitations on opportunities for these training programs. What was the rationale for this? I don't know if it predates your time on the board, but I'm curious if there have been any recent conversations about reconsidering that.
So yes, it did predate my time on the board, but I can share that we do have an LPN school application now. We've had another one that we were reviewing as well. From my understanding, from a historical perspective, a lot of those schools, unfortunately, were kind of just created. And it was a challenge with making sure, which is why they wanted to connect them with a RN program or a university and or a school of nursing, because of really making sure the validity of the education that they were given, kind of leaning into even this Nightingale experience that we are dealing with now. And I do believe a lot of those schools, unfortunately, did not live up to the litmus test that we had prior to me being on the board. And I believe that was the initial challenge. I do know that we have had multiple conversations on the board about how to reopen that pathway and into the RN profession. But even those who want to be an LPN, we need them, which is why we're grateful for our board member, Ms. Margaret Green, who serves as our LPN board member. And we're continuing to make sure we do not create any barriers for them. We just need to make sure that what they're doing and the education that they're providing is meeting the standards that have been created.
Okay. All right. So did you mention that you said there's currently one program that's in process or in review?
Application, yes.
Okay. All right.
So hopefully we'll have two pending them submitting all their information and all the requirements are up to date.
Okay, great. That's
Yes.
good to hear. I mean, again, when I think about some of our challenges and needs around workforce, and even on, what we talked about at the beginning in terms of school nurses, right? I could use an LPN in the school health suite in the same way that I can use an RN as well. But if I'm not getting more people, it's sort of stifling the pipeline just a bit. All right. See.
Not to belabor that comment, Madam Chair, but I do want to share just nationally, there's always challenges, and that's why I'm grateful to go to the National Council of State Boards of Nursing. There's this huge push out there for magnet status, right, in hospitals, and there's a huge push to make sure that the entry level is BSNs. There's a huge push, even having done some consultancy work at a nursing home where you have one RN to 20 or 30 patients, and then the LPN really is mitigated to just passing med. So I think that's a much, much larger conversation about how we can actively reintroduce LPNs into the workforce, because I can speak to, again, even acute care settings actually no longer used LPNs, but now because there's a shortage, now we want to go back. So just the overall profession of nursing really has to pause and create a standard, live by this standard, and not just flip-flop because of the need, without making sure and seeing how that actually really is a disparity for Black and Brown individuals, as well as and a social economic disparity, because LPN programs in the past were pathways into becoming an RN, right? And we don't want LPNs to feel or believe they're just glorified techs. They are a nurse, they are a professional nurse, that we need them, but we have, again, it's a much, much larger conversation that we don't have time for today.
But I think it's an important one to be had. And I think, the additional context you provided is just very interesting there, right? There were, acute care settings weren't really feeling LPNs, and now you need them. But because we've disinvested in those programs and truly building a pathway, now they're not there when you need them. And so we're all trying to do this work together. Okay. So in the Health Occupation Revision Act as introduced, it proposes to merge the Board of Long-Term Care Administration, which currently oversees the licenses for nursing home administrators and nursing home administrations, with the Board of Nursing. Do you think that the Board of Nursing has sufficient staff and expertise to add long-term care to its plate, in addition to all the other licenses that you already do?
So we kind of briefly had a conversation. It's a very small number. I believe it's less than 50 or around about 50. So we are nurses and this is what we do. And I'm sure that we will be able to meet the task. But we also know that the long-term care will not lose its voice. And quite frankly, it could be value added. And we will just continue to work and make sure that our board staff, again, kudos to them because they're doing the work. And yes, it would be great if they had more people. More people doesn't necessarily always mean it's better, but making sure that they have the tools and the resources and the IT support to get all of these things done, I think would be helpful. But no, we are ready and able if that is the desire.
Okay. In terms of, so the board doesn't just deal with licensure, you also deal with investigation and disciplinary actions.
Yes.
What trends are you all seeing in those particular cases?
So some of the initial trends were around, or most recently was the Florence Nightingale case that we spoke to. A lot of it was also fraudulent time cards that were received from CNAs and HHAs, and also unfortunately dealing with positive criminal background checks. Most times it's very cut and dry. We're grateful once we get the investigative report where we can make a decision. Sometimes it's kind of something that might have happened, 10 years ago or whatever. So with great legal counsel, we bring those individuals in. We don't just say no. We actually take time and follow the just process and due process with them, and they're able to have those conversations with us directly. And then we, go into executive session, counsel with our legal attorney, and then we go ahead and move forward with that. But most of it is criminal background checks, a lot of fraudulent time cards. As I said before, those HHAs or CNAs will clock in one place and then leave and go another place. We're like, how did you work 100 hours in 1 week? And so a lot of that is, unfortunately, that Medicaid fraud.
That's what I try to tell these folks. I'm like, when you may think that it's just, oh, it's not that big a deal, but when you start, frauding the federal government, then it is referred to the Office of the Inspector General, and then actions are taken on that side, right? That's not DC alone.
Correct.
And yeah, we've definitely
and it's hundreds of thousands of dollars. It's not just like $20,000. It's a lot of money.
Yes. And I would say probably it's not necessarily a new trend, but also we've definitely heard a number of things about that. And it's just so unfortunate because, right, I want district residents to be able to age in place, and they can't do that if they don't have the qualified workforce to be able to provide the assistance for those who might need a couple of things here or there. And so that's unfortunate. That's the bulk of what you guys are seeing. One last question. So according to the pre-hearing responses, DC Health conducted workforce surveys for each of the boards in FY23. It was noted that the Board of Nursing has successfully completed their renewal process for LPNs, and that the fact sheets will be available on the board's website by the end of the month. What were the preliminary findings from those surveys for the Board of Nursing?
So we're still going through those findings right now.
Okay. All right. So that's why you say we'll have it up at the end of the month.
Yes,
okay.
ma'am.
So we'll come back to that.
I can also share with you that we had a workforce survey that we've already discussed from the National Council of State Boards of Nursing. When nurses are renewing their license, they have an opportunity to respond. And so a lot of it is just burnout is really number one, pay is the other. And then also for advanced practice, kind of the payment in order for you to go ahead and proceed to a further degree in nursing, whether it's master's or your DNP. And so looking at opportunities for nurses to further their education. So that's kind of the common themes is right now nursing burnout for obvious reasons, particularly coming out of the pandemic.
Got it. Okay. Is there anything I haven't asked you that you want to say for the record?
For the record, I want to take a moment and sincerely thank all of the DC Board of Nursing staff members and also my board members. We come here often. We spend many hours. I know that all of our healthcare professionals, and I say that jokingly, but I do mean that nurses truly are the backbone and bloodline of nursing. But I do want to thank Dr. Terry Walsh and Dr. Pan Ravi, our board attorney, and all the other staff members, Kathy Boris Hill and others. They work overtime. Councilwoman, we text, call each other. Terry and I speak often on a Saturday or a Sunday. Pan Ravi, the board attorney, will do the same. So I really would like for you all to acknowledge the work that they do. And even Aisha Nixon, who is our lead here, and Mateo, who helps even prepare me for today. So I want to take a moment and acknowledge all of them. But I will share that there is a national nursing crisis that we do need some help with. And I would implore and honor and welcome you to maybe join one of our next meetings. I know that DC Health is moving soon, but we would love to have you come so you can learn more and hear more about the things that we kind of alluded to with the LPNs and the CNAs and pretty much all the nursing drama that we deal with on a day-to-day basis, and just really thank them for what they do. But if there is a way that you can kind of continue to push to make sure all of our websites and the technology is improved and that they have the tools and resources that they need from the staffing, because again, licensing 50-some thousand people is not a yeoman's job. It's not an easy job that we can do without your support and the government dollars as well. So thank you for this opportunity.
Thank you. And just a couple of follow-ups. We'd love to have the timeline to finalize the certified professional midwife regulations, the written testimony on the direct care worker bill, and then, also a little bit more detail on terms of why not enter a reciprocity agreement with Virginia as well. But thank you so much for your time. Good to see you as always.
Likewise. Have a great day. Thank you so much.
You too. Happy Valentine's Day.
Happy Love Day.
All right. So we're going to go to the Board of Massage Therapy. So we'll give them a minute to transition. The chair is Johanna Brooks. All right. I see the name Erica Walker, so perhaps Ms. Brooks isn't testifying, but whenever you guys are ready.
Good afternoon, Chairwoman Henderson. I am Erica Walker, Executive Director for the DC Board of Massage Therapy. I am giving testimony for the Board of Massage Therapy Chairperson.
Okay. Got it. All right. No problem. Go ahead.
Okay, wonderful. Good afternoon, Chairwoman Henderson, members of the Committee on Health and staff. I'm sorry, Chairman Henderson, one moment, please. I apologize, it's a little technical difficulty.
No problem.
Thank you. Good afternoon, Chairwoman Henderson, members of the Committee on Health and staff. My name is Erica L. Walker, and I serve as the Executive Director for the Board of Massage Therapy. Today, I am pleased to present testimony on behalf of the Chair of the District of Columbia Board of Massage Therapy, Johanna Brooks, on behalf of Mayor Muriel Bowser and DC Health Director Ayanna Bennett. I am pleased to offer this testimony. Sorry, it's still a little more technical difficulty. I apologize. I am pleased to present testimony on behalf of the Chair of the District of Columbia Board of Massage Therapy, Johanna Brooks, on behalf of the Mayor, Muriel Bowser, and DC Health Director, Dr. Anna Bennett. I am pleased to offer this testimony highlighting the activities and overall performance of the Board of Massage Therapy during fiscal years 2023 and 2024 to date. The board chair, Johanna Brooks, has been a licensed massage therapist since April of 2000. She's been practicing for 14 years in the District of Columbia. Her career journey has been diverse, spanning various settings from private offices to world-class spas and collaborating with other allied professionals like chiropractors and medical doctors. Until March 2020, she was the CEO and founder of On-Site Massage, managing over 30 therapists and providing services to corporate clients and events. Additionally, she held leadership roles in professional associations, including vice president of the DC chapter of the American Massage Therapy Association. She joined the board in September of 2018 and has played a crucial role in upholding high standards for massage therapists in the district. In June 2023, she assumed the position of board chair. Ms. Brooks advocates for enhancing education requirements and fostering a holistic approach to massage therapy with the goal of ensuring a positive, safe, and healing experience for the public we serve. As board chair, her responsibilities encompass overall board meetings, equitable treatment for massage therapists, interacting with the board, and safeguarding the public. The District of Columbia Board of Massage Therapy serves a vital role in regulating the practice of massage therapy, overseeing a diverse community of professionals dedicated to promoting health and wellness. The board is one of 19 health professional licensing boards within the district responsible for licensing massage therapists through the review of applications for licensure, receiving and reviewing complaints, requesting investigations, and recommending the standards and procedures for the profession. The Board of Massage Therapy has 3 active members out of 5, with 4 designated as licensed massage therapists known as LMTs, and 1 as a consumer member. Currently, there are 2 board vacancies designated for LMTs, with 2 pending LMT applications with the Mayor's Office of Talent and Appointment known as MOTA. The board meets bi-monthly and is supported by an executive director, board attorney, health licensing specialist, and an investigator who supports the operational needs of the board. As of February 2024, the board licenses 639 massage therapists. This number reflects a 30% decrease since 2019, a decline directly attributed to the impact of COVID-19 on the entire health professional industry. During the pandemic, massage therapists who typically operate in a broad variety of settings face unprecedented challenges, and 100% of LMTs were suddenly unable to work. Unlike other allied health and medical professions, massage therapists could not pivot to online or telehealth services due to its hands-on nature. With no income to cover basic living costs such as rent, utilities, and food, paying for continuing education units, CEUs, became unfeasible for many. Consequently, many practitioners left the profession to pursue alternative career paths. Recognizing these challenges, the board voted to permit all CEUs to be completed online, which is a departure from the pre-COVID requirements of 6 hands-on massage technique courses conducted in a live classroom setting. The primary reason behind this move was the catastrophic event on the industry, rendering in-person workshops unavailable. The absence of such workshops, coupled with concerns about health, safety, and financial considerations, led the board to prioritize online options over traditional classroom settings. Massage therapists play a crucial role in the health and well-being of district residents by providing therapeutic treatments that alleviate pain, reduce stress, and promote relaxation. They contribute to the overall health of the community by improving circulation, enhancing immune function, and aiding in the recovery process from injuries or surgeries. The Board of Massage Therapy, as a member of the Federation of State Massage Therapy Boards, ensures the practitioners are well equipped with the knowledge and skills necessary to deliver effective and safe treatments. The FSMTB serves as a forum for collaboration among state massage therapy regulatory bodies, aiming to promote consistency and excellence in massage therapy regulation across the United States. In the past, the board has embarked on several important initiatives to address challenges within the industry. These initiatives include adopting best practices for investigating, reviewing, and following up on cases and complaints involving sexual misconduct and unlicensed practice. The board is focused on addressing these issues by collaborating with key stakeholders such as the DC U.S. Attorney's Office, Sexual Crimes Unit, Metropolitan Police Department, Sexual Assault Unit, and the Department of Licensing and Consumer Protection to improve board operations and case resolution. Additionally, the board is updating its current regulations to align with national best practices for education, examination, continuing education requirements, and updating professional practice language. Furthermore, the board is reviewing the Interstate Massage Therapy Compact to determine whether it's in the best interest of the district to enter. On behalf of the Board of Massage Therapy, I extend our gratitude to the committee and the entire council for your ongoing support of the district's healthcare workforce. Thank you for the opportunity to testify before the Committee on Health, and I am available to address any questions you may have at this time.
Thank you so much for stepping in. We appreciate that. Let's start with the current makeup of the board. So in the pre-hearing responses, you all said that there was 3 vacancies, but it sounds like from your testimony that there are only 2. Can you clarify?
No problem. Thank you for that question. Currently, we have 2 LMTs who are on the board to include 1 consumer member, leaving 2 vacant LMT positions at this time.
Okay. And you all have submitted names to MODA, or I think you might have mentioned that someone is in process and review?
Yeah, there are 2 LMT applications that are currently under review within MODA's office.
Okay. All right. So, if you've listening in, I've talked to some of the other board chairs about the Health Occupation Revision Amendment Act. We did hold a hearing on that, but that bill is long and involved and various things. I'm curious why DC Health didn't propose merging this particular board with anyone else, as they have seemed to do for other boards. Did you happen to have a conversation with DC Health about this? Why they decided to leave you separate? Considering, when I think about the scope of practice in terms of the work that the massage therapists do, I could potentially make an argument that there is another board that it could be consolidated with.
Mm-hmm. So yes, as mentioned, I am the executive director for the DC Board of Massage Therapy, and this is a board that meets monthly. So we are very much regularly involved in reviewing the board's requirements and identifying what the board's needs are. And based on some of the trends that we have seen and have taken place relative to unlicensed practice, dealing with matters relative to sexual misconduct and sexual assault, to boundaries issues, we think it's very important that this board, in order for the protection of the public relative to this practice, remains its own separate board to meet those needs.
Okay, that is helpful. I guess I was going to ask a question later in terms of the types of complaints that the board most often receives, but it seems from what you're saying, unlicensed practice and sexual misconduct.
Yep, so, unlicensed practice, boundary issues, and sexual misconduct or sexual assault.
Okay. All right. So you also mentioned in your testimony that I think we have a little over 630 licensed massage therapists in the district. This is a decrease from the pre-pandemic days, 35% since 2019. Overall, are we seeing a rebound in terms of the interest in the profession, or is this the new normal?
I think that we will definitely see a rebound with the profession. Nationally, we are seeing that for working with our national organizations, that there is an increase in massage therapists within the national within other jurisdictions. To include, we looked at some statistics relative to the increase in the industry, and we do see that there will be at least an 18% increase by 2025.
Oh, okay. So we're anticipating a rebound of things.
Correct, yes.
Great. You mentioned that the board meets monthly. I know that's not the case for all of, I'm sorry?
I apologize if I said monthly, the board meets bi-monthly.
Bi-monthly. Okay. All right. I thought when you said month, I heard monthly and I was like, wow, that's a lot. What's going on?
Bi-monthly, and clearly from some of the things I identified as some trends and matters that we deal with within the Board of Massage Therapy.
Right. Okay. On that front, so it took on average about 27 days for a massage therapist license to be approved in FY23. Is this about normal or was there an increase in FY23?
Yeah, it's about normal. Please note that and that was just to approve the application and not taking in consideration that we do review applications within 3 to 5 business days, and we notify the applicant of any missing information. And then it'll be incumbent on the applicant to submit, whether it is the transcript, complete the criminal background check, or even after receiving all the information, if it needs to go to the board for full review, it is done at that time. Again, like I said, it's a bi-monthly meeting, so we're able to review applications a little quicker outside of our quarterly boards that outside of our boards that meet quarterly. So therefore, it is considered to be average in those circumstances.
Okay. Do you ever talk to the EDs of the other boards in other jurisdictions to sort of do it like a benchmarking, if you will? Right. I always find it to be interesting where, you know, we'll give what the average is and then someone will say, well, in Virginia, I got an email back in 2 weeks. And I'm like, well, what is Virginia doing that we're not doing, especially considering our numbers are smaller here? So I'm curious, do you talk to your colleagues in these other jurisdictions to sort of get an understanding of what their processes are and perhaps how we might be able to improve here in the district?
So while we do have discussions with our colleagues in other jurisdictions, we have not had a focal point conversation relative to the benchmark of processing of applications and approval rates, but that is something that we can definitely take into consideration and include in our conversations that we have with them.
Okay, great. I think that's just always helpful to know, especially I don't want to ever have a situation where someone's like, well, I'm just going to get my license in Virginia because they're moving faster than DC. So it's always good for us to kind of know what's going on. On that front, I think you mentioned that you all are starting a conversation about a compact. Is it a national compact or a regional gathering?
And I'm sorry, and I do apologize. And I just want to add one more note to the last comment relative to collaborating with other jurisdictions. And just also please note in the state of Virginia that Virginia does not require a criminal background check. So that would
okay.
So please keep that in mind as we do report back relative to how we compare with our bordering states. That is an outliner.
Okay.
Okay. In reference to the compact, so the national organization FSMTB, the Federation of State Massage Therapy Boards, we have been meeting with them relative to the compact, and currently right now they need at least 7 states to be part of that compact. There's only 1 that is part of that compact. The board is looking at the compact, but one of the concerns that we do have relative to that compact is revolved the disciplinary concerns.
Okay.
Ensure that it is definitely economical and is able going to continue to protect the public in the District of Columbia. So with that said, we're continue to have conversations. As a matter of fact, I'll be in a mid-year meeting, I believe in April, where that is one of the agenda items for us to come together to receive any updates relative to the compact and recommendations that our national organization is making.
Okay. In terms of the overall objectives of the board, what would you say as the ED were the major accomplishments of the board over the last year, and what areas are you all focused on for this current year?
Sure. So I think if you don't mind, I'd like to start with the latter. So our focus is definitely to collaborate with the sister agencies that I've mentioned in my testimony because of some of the investigative the complaints that have come our way to the board relative to sexual assault, boundary issues. And those are matters, of course, that, we take very seriously. And we want to ensure that we do partner with those organizations, those agencies who play a part in being able to help us manage enough for us to have better investigative outcomes. So we actually started those conversations. We've actually even met with the U.S. Attorney's Office. And as of last week, we're very proud and that because of that conversation is that they were able to include in one of our LMTs who was arrested for sexual assault, who was licensed in the District of Columbia. And they were able to include in his bond release order that you are not allowed to practice either paid or unpaid in the District of Columbia. Well, prior to us meeting with the Attorney General's office, that language was not included in their bond release. And then therefore, these people were allowed to continue to practice until we were able to summary suspend them. And of course, as you know, our goal is to protect the public. To include, we are continuing these conversations with the Metropolitan Police Department Sexual Assault Unit so we can have received information beforehand as we're dealing with our licensed massage therapists so we can best ensure that we're putting the enforcement and disciplinary matters in place from the DC Health side. To include, we're collaborating with the DC Office of Consumer Licensing and Protection to talk with them about massage therapy establishments, just to make sure that we are communicating with the right people over there whenever we identify unlicensed practice or anyone who we plan on summary suspending.
Okay. All right. That's helpful. In terms of the board's conversations around how to elevate accessibility of massage therapy services across different communities within the city, how is the board sort of working on this? How do we elevate it such that massage therapy isn't something that's only happening in one quadrant of the city, but it's something that is available to residents across the board?
That is something actually even now our board chair has brought to the board's attention. And this is something that we are going to be looking at, something that we need to, and it's also going to take place with the partnerships that we're also in the process of, that we are developing with our sister agencies. First, having a clear understanding of where are these establishments within the District of Columbia, ensuring that these establishments are legally practicing in DC. And once we're able to clearly understand that, then we can begin looking at to see how we can ensure that this profession is looked at as a health profession and a profession that people feel very comfortable and confident in going to, and that it is equitable within the District of Columbia. So that is a matter that is on the board's agenda to take a look into.
Right. Is there anything I haven't asked you that you wanted to put on the record?
Just very thankful to my team who works with, in particular, Ms. Thelma Fusu-Mensah, who is the health licensing specialist for the Board of Massage Therapy, who's done an outstanding job and very particular in reviewing every document to ensure that every person meets the requirements for licensure in the District of Columbia, and ensuring that the board is up to date with the most updated information that the board needs to be made aware of. Very thankful to our current board members because we have been operating with between 2 to 3 members since we recently got a consumer member who has done an outstanding job with helping with the reviewing of applications and making themselves available when dealing with any legislative matter and also updating the regulations. So I do appreciate all the work that they do and of course all the great work here at DC Health with all of our leaders.
Great. Thank you so much. I don't have any further questions for you, so I appreciate you being here. We're going to go to our last person, Dr. Daniel Tisch, who is the chair of the Board of Veterinary Medicine. But we'll give it a moment so you guys can transition over at DC Health.
Thank you.
Dr. Tish, are you ready? There you go. Hello. Good to
morning.
see you. All
Thank
right. Before you get started, just need to swear you in. So if you could raise your right hand. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth?
I do.
Great. Whenever you're ready.
Good morning, Chairperson Henderson, members of the Committee on Health and staff. My name is Dr. Dan Teich, and I have the honor of serving as chair of the District of Columbia Board of Veterinary Medicine. On behalf of Mayor Muriel Bowser and DC Health Director Dr. Ayanna Bennett, I am pleased to provide this testimony on the Board of Veterinary Medicine's activities and overall performance in fiscal years 23 and 2024 to date. I've had the opportunity to advance the veterinary profession and protect animal safety in the District of Columbia through almost 8 years of service on the Board of Veterinary Medicine. In 2022, I had the privilege of becoming chairperson of the board. Outside of my board service, I am a practicing veterinarian and founder and part owner of District Veterinary Hospital, a network of 3 veterinary practices providing compassionate care throughout the district. Prior to my current role, I served as a medical director for an animal shelter and worked to ensure that the most vulnerable animals in the district received access to quality veterinary care. I've been licensed as a veterinarian in the district for almost 20 years now after receiving my doctorate in veterinary medicine from The Ohio State University. The Board of Veterinary Medicine protects and enhances the health, safety, and welfare of animals and the public. We do this by licensing veterinary professionals and developing, promoting, maintaining, and diligently enforcing high professional standards that govern such professionals. As of February 1st, 2024, the board has issued 387 active veterinarian licenses within the district. Specifically, the board reviews applications, issues licenses, and takes disciplinary action when needed. In addition, the board develops and recommends regulations, standards, and procedures. The board is composed of 5 members, 3 veterinarians, 1 veterinary technician, and 1 consumer member. The board currently has 1 veterinarian vacancy due to the sudden departure of a board member, which we are actively trying to fill. The board meets monthly, during which the board not only discusses matters relating to the regulation of veterinary professionals, but also the broader animal care and control related issues. Over the past 5 years, the district has seen a significant growth in the animal care industry. The number of licensed veterinary facilities has increased 48%, and the number of licensed veterinarians has increased by 45%. These increases are partly a result of the demand district residents have for animal care and highlight the important role this board has in keeping animals and the broader public safe. While veterinary professionals may not directly serve people, they play an important role in the district's overall health care system. This is particularly important in the prevention and spread of zoonotic diseases. According to the Centers for Disease Control and Prevention, the CDC, more than 60% of known infectious diseases that impact people can spread from animals. This focus is a critical component of the One Health approach, a recognition that animals, human, and environmental health are all connected. The Board of Veterinary Medicine has worked diligently over the past year to advance the profession in the district. As part of its licensing responsibilities, the board oversaw the successful renewal of veterinary licenses, which ended December 31st, 2023. 74% of all licensed veterinarians applied for renewal, of which 97% have already been approved. These renewal applications are carefully reviewed by health licensing staff members and take on average 3 weeks to approve. This 3-week period is needed to receive supporting documentation from licensees, which for this renewal cycle included a full audit of continuing education documentation. I would like to take this opportunity as well to acknowledge the diligent and thorough work of DC Health staff in supporting the board to manage this important responsibility. The board has also worked to empower veterinary paraprofessionals in the field by licensing both veterinary technicians and veterinary euthanasia technicians. DC Health has issued regulations for these professionals and has finalized an online application portal. These licenses will soon be available to the public as DC Health finalizes the fees and final details, including a grandfathering process for existing veterinary professionals. Once available, the board will conduct an intentional outreach process to ensure that eligible professionals are aware of this new licensure requirement. The board looks forward to this implementation as it will strengthen the veterinary field while also providing greater oversight of those providing care to district animals. Finally, the board has been working with DC Health's Division of Animal Services to establish regulations for non-veterinary animal care facilities. These facilities are not currently regulated by DC Health, and given the national best practices, the board will be advising the department on these regulations to ensure these facilities operate with a high level of animal care. On behalf of the entire Board of Veterinary Medicine, including my fellow board members, thank you to the Committee on Health and the entire council for your continued support of animal welfare and the district's healthcare workforce. I appreciate this opportunity to testify before the committee, and I look forward to answering any questions you may have at this time.
Thank you, Dr. Teisch. Did I say that
Pleasure.
right? Great.
You did. Thank you so much.
Okay. All right. So let's start with vacancies. So you said you guys have one vacancy and you have submitted a name, or you guys are, I guess, at the beginning stages of actively trying to recruit someone for that position?
As of right now, I don't know that we have an active name submitted. This departure was very recent.
Okay. Well, yeah, I mean, in our pre-hearing responses, I had in my script here, they're supposed to praise you guys for not having any vacancies. So this is very recent. But okay, we'll make sure we get that taken care of. In FY23, it took an average of 46 days for veterinary applications to be approved. Would you consider this a normal timeline, or is this longer than normal?
It's not longer than normal. The biggest part for our licensees is the criminal background check waiting time.
Okay.
And for, we also wait generally because we have to receive documentation, especially for a new licensee, from other jurisdictions. And sometimes these things can take quite some time to receive, and that's beyond the control of our own board. The turnover rate, once the information has been received, is extremely fast.
Okay. And maybe I could ask DC Health this, but about how long is it taking for criminal background checks to get back to you?
On average, I was informed it can take about 5 days currently. But remember, we also have to have the licensee also has to apply for the criminal background check too.
Got it. Okay. You all, in addition to licensing, obviously deal with complaints and other disciplinary actions. What type of complaints is the board receiving most often, and what are the trends that you're sort of seeing in the disciplinary cases?
Within the past year, the Board of Veterinary Medicine has received 3 complaints from members of the public regarding animal care from veterinarians. They generally are concerns that they have with the quality of care or the standards that were applied by the healthcare professional. Okay. And 3 was our past year, and that's about average for us as a board.
That's not bad. Okay. It's so interesting to sort of ask that question after just talking to the Board of Massage Therapy, because I'd imagine you wouldn't get very many unlicensed practice cases in veterinary medicine, since that's a pretty specialized field of work. Okay, so this will be an interesting question given your background, but I'm just going to go forth and see where we land. So over the last several months, including at DC Health's Performance Oversight hearing, we've had we received significant public concern and comment about the DC's animal control contract. I'm curious if the board has discussed this concerns, or if concerns have been raised to the board about what's been happening in terms of animal control and care in the district.
The Board of Veterinary Medicine regulates the licensure of veterinary healthcare professionals, veterinarians, and soon-to-be veterinary technicians. The animal care of at the shelter, et cetera, is beyond the purview of the board. So at this time, we are not commenting, or we can take no position on the animal shelter and animal care in the city from non-veterinary facilities that we don't receive a complaint against a licensee.
Okay, so who's responsible for, I guess, doing the checks in terms of veterinary facilities? So not just the people who are serving, but the places where things are happening?
Veterinary facilities are regulated and inspected by DC Health.
Okay, but that's outside of the board's purview.
It is outside the board's purview. That being said, the veterinary facilities, if it's a veterinary hospital, are all have a veterinarian of record for each facility. And if there is a facility problem, the licensee that is the veterinarian of record for that facility may be accountable for the facility itself, but not the facility itself, if that is comprehensible.
Yes, no. I understand. Understood. Okay. So in terms of the work of the board, what were some of the major objectives that you all had for this past year, and did you meet those?
The board had a very active past year. This past year, the board saw the licensure of veterinary technicians and veterinary euthanasia technicians come to fruition. The board's also overseen a transition to an online renewal process for all veterinary licenses, which has been very efficient. The board is also engaging DC Health with coming up with with standards and regulations for commercial facilities, such as dog daycares, et cetera, to help DC Health come up with standards for them. They would not be regulated by the Department of, but they would be regulated by the Department of Health, but not regulated by the Board of Veterinary Medicine. But the Board of Veterinary Medicine is providing knowledge and providing professional judgment as to what is important for these facilities.
A technical assistance, if you will.
Absolutely.
Which is great to hear. I mean, honestly, again, like I said to a board chair earlier, I think all of our 19 health professional boards, you have people on there who knows the day-to-day of the work that we're trying to do. And so it's good to hear that they are consulting with you all on the standards around doggy daycares and some of these other facilities, even if it doesn't ultimately fall under you all. But I think you're able to provide some expertise on that front there.
Absolutely.
Are there any changes within the scope of practice of veterinary medicine that you all are considering right now?
Not that I can think of with the scope of veterinary practice itself. We're continuing on the same lines that we have for quite some time. There's just been a large increase in the number of veterinarians in the city over the past 5 years, along with a large increase of veterinary facilities. The thing that we are looking at for currently and starting to address is the implementation of telemedicine within the city and how we as a board will regulate telemedicine to ensure the best quality care that the city can provide.
I'm not skeptical of telemedicine. It could work, but when I think of telemedicine for an animal, I'm sort of like, And I say that as a dog owner myself, that I'm just curious in terms of how that would work. This increase in the number of veterinary staff, et cetera, and facilities over the last 5 years, what would you attribute that to?
A number of different factors. As the city has grown and as there's been more development in certain areas of the city, that certainly is part of it. I would be remiss to say that the COVID-19 pandemic has not possibly increased pet ownership within the city. And so that certainly is part of a factor. And also this is a national trend where you're seeing more and more people provide more care to their pets as the people start treating them more and more like family members versus simply being a pet. And here in the district, we have a lot of people with a lot of pets that come in. So we're certainly seeing that as part of the increase. And also there's also an economic reasoning for it, as the city previously for the past 20 years has been underserved by veterinarians and by veterinary practices. So we're seeing, I think, partially a rebalancing.
Okay.
As well.
Yeah. in that same vein or similarly, maybe you could just speak to this from what you're hearing from other practitioners in the field. So even though we're seeing this increase in number of practitioners and facilities that are coming to the district, still right now, we don't have a veterinary clinic or services that are offered in Ward 7 and 8. When you talk to your colleagues and peers in the field, what seems to be the barrier to creating some further access east of the river for veterinary care?
Speaking as an individual, not on behalf of the board.
Yes. Mm-hmm.
Thank you. Part of it is location, probably a location assessment, and part of it also might consider as well economics behind the facility. The district is generally been considered by a lot of veterinarians to be an expensive place to practice medicine and set up a facility. So I think that's part of it. As well.
Okay.
That's a large part of the factors that we're seeing, as well as veterinary medicine is private pay.
Oh, I know. Yes.
Yes. That's definitely part of it, and that definitely contributes to the disparity of veterinary care in certain areas of the city.
Yeah. That's one of it's not even just veterinary care. I've been on this crusade since I've been on the council around just sort of providing general same amenities across the board, regardless of zip code. And I've been working for this would be year 4, but we're going to open it this year to even just get a dog park east of the river. Like, we got dog parks literally around the city. We don't have a single dog park in Ward 7 and 8, and they're pets over there. So there really isn't a reason as to why not. So I'm saying that so you don't think that we're just sort of sticking on why there's no veterinary medical care, but we're also not even providing the same type of pet amenities east of the river that we provide for everyone else across the city too, from the government side. So that's us needing to do better on that front. In that regard, in terms of, there not being insurance, which is the same, the conversation we've had with other boards, should there be some type of, and I'm asking you as
individual
who has many years of experience and expertise in this field, but also a knowledge base of what's happening in the markets across the country. Are there specific actions we should be doing more of to help support pet owners who cannot afford traditional veterinary care? I don't know if there are other jurisdictions who do some sort of uncompensated type of care where folks can come in for spay neuter, but even beyond that, I don't know, your dog had a bite and you want to get it checked out before it's infected, but you don't have the services to be able to do that. And then that kind of spirals out. I'm just curious what you're sort of seeing happening in this field around that.
What we're seeing currently is emergency care is definitely increasing in cost, which is definitely providing a barrier to pet ownership and adequate pet care for many people. There are some subsidized low cost care available in the city. It certainly, from an opinion of somebody who's been practicing for a very long time here, it's inadequate at this current time. It is definitely inadequate. The problem that you see is that unless there is some sort of way to support the veterinarians and support the veterinary facilities, it's going to be very tough to see a private group come in that doesn't have outside funding that is going to be able to afford to provide such services here in the city. And there's that's something that in a number of other jurisdictions that the local animal shelter gets city funding or state funding to then provide the services at a discounted rate for the public. And the district needs more of an outreach effort and cohesive way of helping with this, especially in considering spay neuter, because without that, what happens is that you wind up with more unhoused animals and animals that wind up in the shelter in the first place, perpetuating the cycle of animal homelessness and potentially even abuse.
Yep, on that front. Is there anything else that you want to say for the record that I haven't asked you?
I appreciate your attentiveness to these to veterinary medicine and to giving this board, of course, a platform. I think that veterinary medicine has done very well over the past years, and this board is an excellent board, and I want to thank our board staff as well. This board had a 100% audit of every licensee renewal, and I would just like to thank our health professional licensing for that. It's the only jurisdiction in the entire country that has audited every single applicant and or renewal. So to the Department of Health staff and health license staff, I want to say a very hearty thank you. And the Board of Veterinary Medicine is, of course, always happy to help with any concerns or questions that council has that we can help and provide professional feedback.
I appreciate that. And thank you so much for your time and for being here today. I don't have any further questions. So I want to thank you. I want to thank Mila Kaufman. I want to thank Dr. Nara. I want to thank Ms. Barnelli, Ms. Walker, for being here, for your testimony, and for engaging in a very robust conversation. That concludes today's performance oversight hearing. So for those of you who haven't submitted written testimony, who would like to provide written testimony, we'll accept public testimony until February 28th at 5 p.m. You may submit your written testimony on the council's hearing management system website at dccouncil.gov/hearings. This is the last of the Committee on Health's performance oversight hearings for fiscal year 2023. You can watch the recordings of all of our hearings on the council website or on my YouTube page at CMC Henderson. The committee's next hearing will be on Thursday, March 7th. We will consider Bill 25-565, the Direct Care Worker Amendment Act of 2023. The time is now 2:03 p.m. and this hearing is adjourned. Thank you so much.